The heart monitor flatlined at 11:47 p.m., and every doctor in that trauma bay froze. Every doctor except her. She didn't reach for the crash cart. She didn't call for backup. She moved to the corner cabinet, the military trauma kit nobody else had ever opened. And she worked with hands that had done this before, in places most of them would never survive. 12 seconds later, the monitor blinked. Then it beeped. Then the patient's chest rose. And when Brigadier General Aaron Merritt walked through those trauma bay doors and looked at the woman in the nurse's scrubs, his face went white. "My God," he whispered, "it's her." Before we go any further, if you're new here, hit that subscribe button right now, because the story you're about to watch is exactly the kind we tell on this channel. Real stakes, real grit. People who get knocked down so hard the whole world thinks they're finished, and then they stand back up in ways nobody sees coming. Don't miss what's next. And when you're done watching, drop a like and tell us in the comments what city and country you're watching from. I want to see how far this story travels. Now let's get into it. The ambulance bay at Hargrove Regional Medical Center smelled like exhaust and antiseptic and wet pavement, and Sarah Voss stood at the intake desk at 6:52 in the morning wearing scrubs that were one size too big and a hospital ID badge that still had her photo from orientation, the one where she looked like she hadn't slept in 3 days, because she hadn't. She was 33 years old. She had been a nurse for 11 years. 8 of those years were spent in places most of the staff at Hargrove couldn't find on a map. She signed in, clipped her badge to her chest pocket, and walked into the trauma wing like she had been doing it her whole life. Because in every way that mattered, she had. Hargrove Regional sat at the edge of Caldwell, Oregon, a mid-sized city that pressed up against the Cascade foothills, with the particular confidence of a place that believed it had figured something out. It was a Level 1 trauma center, the only one within 60 miles, and it operated with the specific culture of institutions that have never had serious competition. The trauma department was clean, well-funded, and run almost entirely on the personality of one man. Dr. Elliot Drummond, Chief of Trauma Surgery, 51 years old. Credentials from Johns Hopkins, a fellowship at Mass General, publications in 3 major journals, and a manner that communicated in every interaction that the room he was standing in was doing him a favor by containing him. Sarah met him on her 3rd morning. She had just finished repositioning a post-op patient with a difficult airway, a man who kept biting down on his oxygen tube whenever the overnight nurses tried to adjust it. She had used a technique she picked up in a field hospital outside Jalalabad, a modified positioning method that kept the airway clear without requiring the patient to cooperate. It worked in 40 seconds. The overnight nurse had been fighting the same issue for most of the shift. Drummond came into the room while she was finishing the documentation. He looked at the patient. He looked at the monitor readings. He looked at Sarah. "What did you change?" he asked. "Head positioning, mostly," she said. His airway was partially occluded every time he moved his jaw. "I repositioned his neck and patted the lateral supports. It'll hold through the morning." Drummond studied the setup for a moment with the expression of a man who has been told something obvious by someone who shouldn't know it. "You're the new nurse," he said. "Sarah Voss, started Monday." "Where did you work before this?" She told him. He made a small sound that was not quite a laugh and not quite dismissal, but lived somewhere in between. "A battlefield nurse," he said. "We run a different kind of operation here." Sarah said nothing. "What I mean," Drummond continued, moving toward the door, "is that field training and clinical training are 2 very different things. This is a tertiary care center. The protocols here exist because they work in controlled environments. What works in a tent in Afghanistan doesn't necessarily apply here." "Understood," Sarah said. He was already gone before the word left her mouth. That was how it started. The nursing staff at Hargrove were not unkind. Most of them were overworked and running on institutional habit, the kind of autopilot that comes from doing the same job in the same building long enough that the building starts to feel like the whole world. They were welcoming enough, in the way that people are welcoming when they don't see you as competition. Sarah noticed that she was never asked her opinion. She noticed that during handoffs, her assessments were summarized by whoever was leading the briefing, often without attribution, and occasionally with minor alterations that stripped the nuance out of what she had actually said. She noticed that when she raised a concern during rounds, the attending physician would nod and then address the question to the person standing next to her, as though the concern had originated there. She let it go. She had been in environments that functioned this way before, and she knew that the fastest way to become visible in the wrong way was to push against it too hard too soon. So she did what she had always done. She worked. She caught a medication error on her 4th day, a decimal point misplaced on a post-surgical anticoagulant order that would have resulted in a dose 10 times too high. She flagged it quietly to the charge nurse, corrected the order, and documented it per protocol. No drama. She wasn't looking for credit. On her 6th day, she identified early sepsis in a patient who had come in presenting with what looked like a UTI. The patient's lactate was trending in a direction nobody else had caught because they were tracking the wrong markers. Sarah brought it to the attending with her reasoning laid out clearly. The attending ordered the sepsis protocol. The patient spent 3 days in the ICU and was discharged in stable condition. Still no particular acknowledgement. She didn't need it. But she noticed its absence, which is a different thing. The problem with Drummond wasn't that he disliked her. It was that he had already decided what she was, and he was the kind of man who rarely revised his first assessments. In his mental taxonomy of the Hargrove staff, Sarah Voss occupied the category of field-trained non-physician, competent at the gross mechanics of emergency care, unreliable on anything requiring advanced clinical judgment, and constitutionally inclined to act outside sanctioned structures because battlefield medicine ran on improvisation rather than protocol. I wasn't entirely wrong about some of the nurses who came through trauma programs with military backgrounds. He had seen a few over the years who genuinely struggled with the slower, more procedurally rigid pace of civilian hospital work. But he had built a profile from a limited sample, and he applied it universally, and Sarah did not fit it. She knew this. She also knew that arguing with a man who had already made up his mind was a waste of energy she didn't have. The shift that changed things happened 17 days after she started. It was a Tuesday afternoon, mid-November, the kind of cold that came in off the foothills with a dampness that got into the joints. The trauma wing was running at about 70% capacity. Not quiet, but not overwhelmed. Sarah was doing a routine assessment on a 19-year-old named Danny Okafor, who had come in through the ED complaining of chest pain after a minor car accident. The initial workup had been unremarkable. X-ray showed no obvious rib fractures, no pneumothorax on the preliminary film. The attending had ordered observation and pain management and moved to the next patient. Sarah stood at Danny's bedside, running through her assessment, and something was wrong. She couldn't name it in the first 30 seconds, which was unusual. Usually her instincts gave her a word within moments of entering a room. A category, at least. This time it came in pieces. The kid was too anxious for a minor chest injury. His respiratory rate was 22, which the chart had logged as within normal limits, but normal limits at rest were different from normal limits in someone who was visibly trying to breathe shallowly because breathing hurt. His trachea was midline, but barely. His neck veins were flat against the surface of his skin, in a way that Sarah had seen before in patients who were peripherally vasoconstricted but compensating hard. She put her fingers on his wrist. His pulse was there, but it was fast and thin, the kind of pulse that was working overtime to make up for volume it wasn't getting. She said very calmly, "Danny, I'm going to listen to your lungs. I need you to breathe normally for me. Don't try to take big breaths, just breathe." He nodded. I was frightened in the specific way of people who feel something wrong inside their bodies but don't know what it is. She put her stethoscope to his right lung field, then his left. The left side was diminished, not absent, but noticeably quieter, the whisper of breath sounds that should have been full-bodied and present. She stood back and looked at him and made the call. Tension pneumothorax, developing. The initial X-ray had caught a normal film because the tension had not yet built enough to show on imaging, but it was building now, and if it continued to build without intervention, the pressure would eventually shift the mediastinum, compromise venous return, and send this 19-year-old kid into cardiac arrest in a hospital bed 20 feet from a nurse's station. She went to the door and flagged down Dr. Reed Horton, the third-year attending on shift. "I need you to reassess the patient in Bay 4. I'm seeing breath sounds diminished on the left, elevated respiratory rate, tachycardia. I think we're looking at a developing tension pneumo." Horton was not a bad doctor. He was overworked and pulling a double, and had already seen 23 patients that shift, and he glanced at the chart she was holding and said, "The X-ray was clear." The X-ray was 3 hours ago. He looked at her. She held his gaze without aggression and without backing down. He went into the room. He came out 90 seconds later, moving fast. He ordered a repeat chest film, a needle decompression kit, and called respiratory therapy on his way back to the bedside. The repeat film confirmed tension pneumothorax left side. Horton decompressed it with a 14-gauge needle. The kid gasped, and the relief on his face was instantaneous, and 20 minutes later he was stabilized and moved to the ICU for monitoring. Sarah finished documenting the sequence and moved on to her next patient. Drummond found her at the medication prep station 40 minutes later. "Room 4?" he said. "Yes," she said. She kept preparing the medications. "You ordered that reassessment." I flagged my concern to Dr. Horton, who ordered the reassessment. "You told him what to look for." "I told him what I was observing and what I thought it might indicate. He examined the patient and made the clinical decisions." She looked up at him. "That's how the chain of command works." Drummond's jaw moved in a way that suggested he was choosing his next words carefully. "You went to an attending with an assessment that contradicted the initial workup." "I went to an attending with new observational data." "You flagged a tension pneumo that wasn't on the imaging." "The imaging was 3 hours old." He stood in the doorway of the prep station for a moment, and she could see him deciding how to frame what he was about to say. Whatever he felt about her being right, and she thought she saw a flicker of something there, something that in a different man might have been grudging respect. It was overridden by something else. Institutional hierarchy. The sense that a nurse recognizing something before an attending physician had been noted, and the implications of that needed to be managed. "You need to understand," he said, "that in a Level 1 trauma center, assessments that contradict the primary workup go through the attending of record first. Not directly to coverage, you created confusion in the bay." The patient presented with a developing tension pneumothorax, and Dr. Horton handled it. "Dr. Horton is who I went to." Drummond looked at her. "You were out of your lane, Voss." Sarah set down the medication cup she was holding. She turned to face him fully, not aggressively, but squarely. "Dr. Drummond, the patient's condition was deteriorating. I brought a concern to the covering physician using the appropriate channel. He evaluated the patient and made an independent clinical determination. I don't understand what I should have done differently." "You should have brought it to the charge nurse first." "The charge nurse was occupied with a patient in acute respiratory distress." "Then you wait." The word landed in the space between them, and Sarah let it sit there for a moment. "I had a 19-year-old with a developing tension pneumo," she said. "If I had waited for the charge nurse to come free, we might have been coding him. That's not for you to determine." She looked at him. She understood in that moment that this conversation was not actually about Danny Okafor. It was about something else, about what it meant that a nurse had seen what the initial workup missed, and what it meant for the established order of things, if that was allowed to stand without comment. "It won't happen again," she said, "because it was the right thing to say in the room and the wrong thing to mean." Drummond left. She turned back to the medications and finished what she was doing. In the days that followed, the story of Room 4 moved through the nursing staff the way stories always do in hospitals, quietly, in fragments, in the break room, and at the nurses' station during lulls. Most of what she heard was secondhand. Danny Okafor's mother had come to the desk asking to speak with the nurse who had found the problem. The charge nurse had told her Sarah was off shift. Horton had written something in his notes that credited the nursing assessment. Someone had mentioned it to someone else. And somewhere in that chain it had been characterized as Sarah having diagnosed a patient, which was not accurate, but which was the version that reached Drummond. He sent an email to the nursing director 2 days later. Sarah never saw it directly, but the nursing director, a woman named Patricia Greer, who had the particular weariness of someone who had been managing institutional politics longer than she expected to, called Sarah into her office and told her, gently but clearly, that Drummond had formally raised a concern about her clinical boundaries. "He's not filing a complaint," Greer said. "He's flagging what he calls a pattern of overreach." "I've been here 3 weeks," Sarah said. Greer nodded with the expression of someone who was not disagreeing with her. "I know, I reviewed the chart. What you did was appropriate. But Drummond has pull here, and you need to be careful about how you interact with his team." "His team is the whole trauma department." "I know," Greer said again. Sarah walked out of that office with the very clear understanding that being right was not going to protect her if the wrong person had decided she was a problem. She had been in situations like this before. Different uniforms, different chain of command, but the same fundamental architecture. Someone with authority, who felt that authority was being challenged by someone with less of it. The outcome was usually a function of how patient the person with less authority could manage to be while not abandoning the thing that mattered. The thing that mattered was the patience. She could be patient about everything else. She went back to work. The morning of December the 9th started like every other winter morning at Hargrove Regional, the night shift handing off to the day shift in that particular fog of exhaustion and caffeine, the briefing room smelling like burnt coffee and someone's breakfast sandwich, the overnight board filled with names and room numbers that represented human beings whose nights had been worse than anyone's should be. Sarah took her assignment, Bay 2 through 6, plus overflow if it came in. She noted a patient in Bay 3 who had been admitted overnight with a complicated pelvic fracture from a construction site fall, a woman in Bay 5 recovering from an appendectomy that had turned complicated around 2 a.m., and 2 new admissions in Bays 2 and 4 still being workup. She started with the pelvic fracture. His name was Gerald. He was 54 years old and looked older, with the kind of hands that told you he had been doing physical labor his entire life. He was in significant pain despite the pain protocol, which Sarah flagged immediately. The ordered dose was appropriate for his weight and age, but his pain response suggested something else was going on. She was checking his vital signs when the overhead page went off. Not the routine page, the trauma activation page, the one that meant something was already bad before it arrived. She heard the details coming through. Multi-vehicle accident on Route 17, black ice, 4 confirmed critical, ETA 11 minutes. And she felt the shift in the air that always preceded a mass casualty event, that particular compression of energy when a building that was already running hot was about to get hotter. She secured Gerald's monitoring leads, made sure his call light was within reach, and moved to the trauma bay. The room was already filling. Drummond was there, which meant this was being treated as a major activation. 2 residents, 3 nurses, including Sarah, a respiratory therapist, the lab cart already being positioned. The characteristic controlled chaos of a trauma team assembling, people moving with purpose around each other in a space that had been designed for exactly this. The first patient came in at 7:19 a.m. 32-year-old male, unrestrained driver, high-speed impact, passenger side intrusion, prolonged extraction. He was intubated in the field, 2 large-bore IVs in, one of them already running wide open with saline. His pressure was 74 over palp. His abdomen was rigid on palpation. His pelvis was visibly unstable. The asymmetry was apparent even through the backboard straps. Sarah looked at the monitor. She looked at the patient. She looked at the paramedic giving the handoff report. "What was the mechanism?" she asked. T-bone, driver's side of a pickup into the passenger door of his sedan. He was pinned for about 22 minutes. She pressed 2 fingers to his radial pulse. It was there. Barely. Drummond moved to the head of the bed and took command of the room the way he always did, efficiently, authoritatively, with the practiced ease of someone who had done this hundreds of times. "Talk to me. Abdomen?" "Rigid," said the resident doing the fast exam. "Free fluid in Morrison's pouch. Significant." "Pelvis?" "Unstable on exam." "Blood pressure?" 68 over palp. "Get me 2 units O-neg, push the saline, and get anesthesia on the phone. We're going to the OR and We need a pelvic binder," Sarah said. The room didn't stop, but there was a microsecond of interruption. Heads turned in her direction. "We need to stabilize the pelvis before we push more volume," she said, moving to Drummond's side. "If his pelvic ring is disrupted at the level I'm seeing, pushing fluid, without binding, is going to accelerate the hemorrhage. He's bleeding into the retroperitoneal space. The more volume we give him, the more pressure we're generating against a fracture site that isn't contained." Drummond looked at the patient. He looked at Sarah with an expression that was complicated. Not angry, not dismissive, but not fully present to what she was saying either. "He needs the OR," Drummond said. "He needs the OR in 5 minutes, not right now. And if we push him there at 68 systolic without binder and MTP, he's going to arrest on the table before they can open him." "I've been doing this for 20 years, Voss." "I know," she said, "and I'm asking you to listen to me right now." The room was very quiet for a second and a half. Then the monitor changed. The blood pressure reading dropped. 54 over palp. And Sarah watched Drummond's face. He was going to intubate. She could see it in the way he was positioning himself, the way his eyes moved to the respiratory therapist, the way his hand came up. "Dr. Drummond," she said, "intubation in a patient with hemorrhagic shock at this level of hypotension and suspected pelvic ring disruption is going to—" "Step back," he said. "Push him into cardiac arrest. The vasodilatation from the induction agents will—" "Step back from my patient." She stepped back. She watched him order RSI. She watched the respiratory therapist draw up the induction agents. She watched the medications go in. And she watched the monitor. 41 over palp. Then 38. Then the line went flat. The silence that followed was the particular silence of a room where something has gone wrong, that everyone can feel but nobody has said yet. Then the resident at the monitor called it, "No pulse. Initiating CPR." The room lurched into the mechanical rhythm of a cardiac arrest. Chest compressions, the charge for defibrillation, the voice of the resident calling the cadence. And Sarah stood at the edge of the controlled chaos and looked at the patient, and she understood something that she had understood for the last 4 minutes. CPR was not going to bring him back. There was no blood to circulate. The compressions were working against a body that had been hemorrhaging into its own pelvis and retroperitoneal space since the moment of impact, and every compression was moving volume that wasn't there through a circuit that was failing. She had seen this before. She had seen it in places where the math of what was happening inside a body was something you learned to calculate in your head because there were no machines to do it for you. She knew what he needed. She looked across the room at the supply cabinet, at the labeled drawer, the REBOA kit, resuscitative endovascular balloon occlusion of the aorta, a catheter inserted through the femoral artery, advanced into the aorta, inflated to occlude distal blood flow, preserve what remained for the heart and brain, buy the surgical team the minutes they needed to control the bleeding at its source. She had done it 4 times. 2 of them without imaging, 2 of them by feel and training and anatomy and the particular conviction that the alternative was standing still while someone died in front of her. She started moving toward the cabinet. "Voss," Drummond's voice. She stopped. I was looking at her across the CPR tableau, across the resident's compressing hands, across the flat line on the monitor, across the controlled failing of everything that was happening in front of them. "If you touch that kit," he said, "I will have you removed from this hospital, and I will have you arrested. Do you understand me?" Sarah looked at him. She looked at the monitor. She looked at the patient, at the 32-year-old man with working man hands like Gerald in Bay 3, at the man who had been pinned in his car for 22 minutes on a black ice highway and brought here on the assumption that here was where people like him came to survive. She looked at the REBOA kit. Then she reached for it anyway. Nobody moved to stop her. That was the thing she would think about later, in the quiet moments when the adrenaline had finally burned off, and she was sitting alone in the break room with cold coffee and the specific exhaustion of someone who had spent everything they had and then spent a little more. Nobody moved. Drummond had said the words, the threat, the consequence, the full weight of institutional authority delivered in 9 syllables. And the room had heard it, and then Sarah had reached for the cabinet anyway, and the room had let her. Not because they agreed with her necessarily, not because they had made some collective moral calculation in the 2 seconds between Drummond's threat and her movement. People in crisis don't do that. What they do is respond to the person in the room who is moving with the most clarity, and in that moment, Sarah was the only person moving at all. She pulled the REBOA kit from the drawer and brought it to the bedside without looking at Drummond. I was standing at the head of the bed, and she could feel his presence behind her like a pressure system, the kind of cold, concentrated fury that exists just before it either breaks or dissipates. She did not know which it was going to be, and she did not have time to find out. "I need someone to hold femoral access on the right," she said to the room. Silence for a full second. Then Dr. Mia Sutton, the second-year resident who had been running the FAST exam, moved to the right side of the bed without a word. She was 28 years old and terrified and smart enough to understand what she was watching. "Thank you," Sarah said. She pulled on a second pair of gloves, located the right femoral pulse by palpation. It was faint, but it was there, the heart still working in the mechanical way of hearts during CPR. And she opened the kit. "Stop compressions," she said. The resident doing compressions looked at Drummond. "Stop compressions," Drummond said, flat. The resident lifted his hands. Sarah worked. She had done this in a forward surgical team tent in the Korengal Valley with a headlamp and no ultrasound and a patient whose blood pressure had been unrecordable for 6 minutes. She had done it on a medevac helicopter in conditions that made this trauma bay look like an operating theater. She had done it with her hands shaking, and she had done it with her hands steady, and both times the outcome had been the same, because the technique was the technique, regardless of how she felt about what was happening. She found the femoral artery. She cannulated it. She advanced the catheter. The room was so quiet she could hear the wheels of the medication cart in the hallway outside. She inflated the balloon. 3 seconds. The monitor blinked. A single blip on the ECG tracing, irregular, weak, but there. Then another. Then a rhythm that wasn't normal, but was something. Pulse, said Sutton, her fingers at the carotid. I have a pulse. The blood pressure cuff cycled automatically. 39 systolic. Then 44. Then, slowly, climbing. Sarah did not exhale. She kept her hand on the catheter and watched the numbers and did the math in her head. How long the balloon could stay inflated. What the hemodynamic target needed to be. When the window for OR transfer would close. It was not triumphant. It was arithmetic. Get OR on the phone, she said. He needs to be in a room in the next 8 minutes. Someone made the call. Drummond had not spoken in 4 minutes. The patient's name, they would learn later, was Marcus Tully. He was 32 years old. He drove a school bus route for the Caldwell Unified District on Monday, Wednesday, and Friday. And on the other days, he worked as a maintenance contractor for a landscaping company. He had a daughter named Brielle, who was 7, and an ex-wife who was still listed as his emergency contact because he hadn't updated the form, and a mother in Bend who would receive a phone call in approximately 3 hours that would change her understanding of the morning she was having. None of that existed in the trauma bay. In the trauma bay, he was a set of numbers and a rhythm on a screen and a body that needed to get to a surgical team before the balloon in his aorta had been inflated long enough to cause ischemic damage to his spinal cord. Sarah walked with the gurney to the elevator. She was not supposed to leave the trauma wing during an active shift without sign-off, but the catheter required continuous monitoring and she was the one holding it, so she walked and nobody stopped her, and Drummond did not follow. The OR was ready on the 4th floor. She gave the handoff to the surgical attending, Dr. Kevin Rao, a vascular and trauma surgeon who had been paged in from the adjacent building, and she explained the catheter position and the inflation pressure and the hemodynamic status in 45 seconds of clean, organized language that Rao listened to without interrupting. When she finished, he looked at her. "You placed this in the trauma bay?" he said. "Yes." "Without imaging?" "We didn't have time for imaging." He looked at the monitor. He looked at the catheter. He looked at Sarah with an expression that was not quite skepticism and not quite admiration, but something that hadn't settled into either category yet. "All right," he said. "We've got him." She stepped back and let them take over and stood in the OR corridor for a moment with her back against the wall and her eyes closed. Her hands were not shaking. That was a good sign. When her hands shook, it usually meant something had gone wrong with the procedure. When they were still, it meant the body had done what the training said it would do. She took a breath. Then she went back downstairs to her other patients. Drummond was waiting for her at the nursing station. Not literally waiting. He was reviewing a chart, standing at the station counter with his reading glasses on and his attention ostensibly on the document in front of him. But the way he angled toward her when she came through the door told her everything about what was actually happening. She signed back in and went to check on Gerald in Bay 3. Gerald was sleeping. His pain score was better. Someone had adjusted his analgesic dose while she was upstairs, probably Sutton, who had apparently returned from the trauma bay with a different understanding of whose instincts to follow. Sarah adjusted his repositioning pillow, noted the improvement in his color, and updated his chart. She was halfway through the update when Drummond came into the bay. He didn't close the door. He stood in the opening and looked at her. "When you're done," he said. She finished the note. She logged out of the workstation. She turned around. "My office," he said. The office was small and crowded with the particular accumulation of a man who had been in the same position for a long time. Journals stacked in a specific order that probably meant something to him, certifications on the wall in mismatched frames, a whiteboard with a half-erased protocol diagram that had been there long enough to become part of the furniture. He sat behind the desk. She stood until he gestured to the chair, and then she sat, which she knew was what he wanted because sitting put her lower than him, and that was the geometry of the conversation he intended to have. "I'm going to be direct," he said. "Please," she said. "What you did in that trauma bay was a serious breach of clinical protocol. You performed an invasive procedure without physician authorization, without imaging guidance, and in direct violation of an explicit instruction from the attending of record. That's not a judgment call. That's a clear line, and you crossed it." "The patient went into cardiac arrest after an intervention I specifically warned against," Sarah said. "Standard CPR was not going to restore circulation in a patient with that degree of pelvic hemorrhage. The REBOA was indicated, there was no specialist available to perform it in the window we had, and I have extensive documented training with the procedure. That is not your determination to make." "Who was going to make it?" Drummond's jaw tightened. "The attending physician." "The attending physician was intubating a patient I told him would arrest from induction." The room went quiet in a way that felt deliberate, the specific quiet of a statement that both people in the room recognized as true, and one of them was not going to acknowledge. "You're saying this is my fault," Drummond said. "I'm saying the patient's cardiac arrest was a predictable consequence of a decision made over my objection," Sarah said. "I'm not filing anything. I'm not making a complaint. I'm telling you what happened in that room because you asked me to be direct, and I'm being direct." He was quiet for a moment. She could see him deciding something. Not whether she was right, she thought, but what the cost of her being right was going to be for everyone involved, including himself. "I'm going to be filing an incident report," he said finally. "The nursing director will be informed. Your clinical privileges may be subject to review pending the outcome." She nodded. "Do you understand what I'm telling you?" "You're telling me you're going to pursue a formal process," she said. "I understand. And I'm telling you that whatever happened in that OR, whatever the outcome for that patient, it does not change the fact that you violated protocol in this department." She looked at him. She thought about saying a number of things. She thought about the way the monitor had looked when Marcus Tully's heart stopped. The flat line, the silence, the feeling of something irreversible beginning. She thought about the moment the balloon inflated and the rhythm returned, thin and ragged and real. She said, "Is there anything else?" He told her she could go. The incident report was filed by end of shift. Sarah saw it through the standard disclosure process, a digital notification to her employee portal with a case number and a summary of the concern. Unauthorized performance of an invasive vascular procedure by unlicensed practitioner outside the scope of nursing practice, in direct contravention of explicit physician instruction. She read it twice. She printed a copy. She put it in the folder she had started keeping in the second week of her employment at Hargrove, the one that contained her own documentation. Dates, times, observations, assessments, the patient in room 4 with the developing tension pneumo, the sepsis catch, the medication error. The quiet, unglamorous record of someone who understood that institutions had a way of revising history in the direction that was most comfortable for the people running them. She went home that evening and ate leftover soup and sat at her kitchen table and thought about the 8 years she had spent in places where the cost of getting it wrong was a body bag. And she thought about the way military medicine had trained her to see the decision tree in front of her, the same way a chess player saw the board. Not one move, but 3. Not the immediate consequence, but the downstream one. The immediate consequence was the incident report. The downstream consequence was what happened to Marcus Tully. If he survived, the incident report became a problem for Drummond. If he didn't, if something had gone wrong in the OR, if the procedure had somehow contributed to a complication, then the report became a weapon. Sarah understood this with the same clarity she brought to everything else. She was not naive about how these things worked. She had watched good people get dismantled by institutional processes that had less to do with what actually happened than with who was in the better position to tell the story afterward. She slept 4 hours. It was more than she expected. She called the hospital at 6 a.m. before her shift started. She did not ask about Tully directly. She was technically off the case the moment she had left the OR, but she had a relationship with the overnight ICU charge nurse, a veteran named Deborah, who had been at Hargrove for 19 years and who had a practice of giving clinical updates in a way that was entirely within professional bounds, while also being completely informative. "Your patient from yesterday made it through the night," Deborah said. Rao's team was in the OR for 4 hours. He's in the ICU on a vent, sedated, but the hemodynamics are stable. Good, Sarah said. You sound like you expected that. I hoped for it. Bit of a difference, Deborah said. Yeah, Sarah said. There is. She hung up and got ready for work. The shift was unremarkable for the first 3 hours. She was pulled from the trauma wing and reassigned to surgical step-down, which she understood was Drummond's doing, a way of removing her from the environment where she had caused the disruption without formally restricting her pending the review. She did not object. Step-down had patients who needed care, and she gave it. Just after 10 in the morning, she was in the middle of a dressing change on a patient 4 days post-abdominal surgery when her phone buzzed, an internal page from Patricia Greer. She finished the dressing change, she washed her hands, then she walked to Greer's office. Greer had the kind of face that had learned to carry news neutrally, and today she was working hard at it. She was sitting behind her desk with a file open in front of her, and her hands folded on top of it in a way that suggested the file contained something she had read more than once. Close the door, she said. Sarah closed it and sat. I've reviewed the incident report, Greer said, and I've talked to Dr. Drummond, and I've talked to Dr. Rao, and I've reviewed your personnel file and your credentialing documentation. Sarah waited. Your military training records include documented REBOA certification from your time with the 67th Forward Surgical Team, Greer said. That certification is current. It was recertified 18 months ago through a military continuing education program. Yes, Sarah said. That's relevant to the incident report. I know. Greer looked at her. She was 54 years old and had been navigating the space between clinical reality and institutional politics for the better part of 3 decades, and she had the look of someone who had developed a complicated relationship with what that space required of her. What I'm about to say is not official hospital position, Greer said. What I'm about to say is me talking to you as someone who has been doing this longer than you've been a nurse. Sarah said nothing. Drummond has real influence here, the kind that outlasts individual incidents. He's been running this department for 11 years, and he has relationships with the board that didn't happen by accident. She paused. The incident report is going to the Clinical Standards Committee. That review process takes 4 to 6 weeks. During that time, your privileges in the trauma department are suspended, pending outcome. Sarah absorbed this. Dr. Rao submitted a statement, Greer continued. He described the catheter placement as technically sound, and the intervention as having been the proximate cause of the patient's survival. That statement is part of the record. But Drummond's account characterizes your actions as reckless deviation from protocol, unauthorized procedure in a chaotic environment, and disregard for the established chain of command. Greer's voice was carefully even. His account also suggests that the patient's arrest may have been precipitated by the delay caused by your interrupting the clinical team. Sarah looked at the desk. She did not say what she was thinking. That's not accurate, she said. I know, Greer said, but it's in the report. She walked out of that office into a hallway that felt slightly narrower than it had before, the way hallways do when the architecture of a situation has shifted and you're aware that the floor beneath you is less solid than it looked. She stood at the window at the end of the hall and watched the parking lot for 30 seconds. The ordinary movement of ordinary people, cars pulling in and out, a man in a visitor badge standing near the entrance smoking a cigarette with the particular urgency of someone whose news inside has been bad. And then she went back to work. 4 days passed. Marcus Tully was weaned off the ventilator on day 3 and transferred from the ICU to the surgical floor on day 4. Sarah heard this through Deborah, who had a comprehensive awareness of patient movement across the hospital that was only technically a function of her role. On day 5, she was called to the nursing director's office again. This time, Drummond was already there. He was sitting in the chair to the left of Greer's desk, with the specific posture of a man who had arrived first, and was aware of that advantage. He was wearing his white coat with the attending badge visible, which was a choice in a room with a nursing director that communicated something about the relative positions he understood to be in play. Sarah sat in the remaining chair. Greer said, Dr. Drummond requested this meeting. I'll let him speak. Drummond looked at Sarah. He had the manner today of someone who had thought carefully about the version of himself he was going to present. I want to be clear that I'm not here to escalate, he said. I think we've had a difficult few days, and I think there may have been a breakdown in communication that contributed to what happened in the trauma bay. Sarah said nothing. My concern, he continued, is that your training background, which is genuine, I'm not disputing that, has created a set of instincts that are very well suited to a forward surgical environment, but that don't necessarily fit the collaborative structure of a level I civilian center. That's not a critique of your skill, it's an observation about fit. You're suggesting I'm in the wrong job, Sarah said. I'm suggesting that the trauma department operates at its best when the team functions as a unit with clear lines of authority, and that your tendency to act on independent assessment, even when that assessment turns out to be correct, creates friction that can be dangerous in a live trauma scenario. Sarah looked at him. She understood precisely what he was doing. It was very well executed. It framed her competence as a liability, her independence as a character flaw, and her military training as an explanation for why she was unsuited for the environment rather than as evidence of her capability. It was the kind of argument that was difficult to answer directly because it wasn't technically wrong about anything while being comprehensively wrong about everything. A patient went into cardiac arrest after an intervention I specifically warned would cause cardiac arrest, she said. I used a technique I'm certified to perform to restore his circulation. He's on the surgical floor. Those are the facts. The process matters as much as the outcome, Drummond said. Not to Marcus Tully, she said. The room went quiet. Greer cleared her throat. What Dr. Drummond is proposing, she said, careful and even, is a voluntary reassignment. Step down in general med-surg, off the trauma rotation, while the clinical standards review runs its course. The incident report remains open, but a voluntary reassignment would allow us to— That's a suspension, Sarah said. It's a reassignment. It's a suspension with different language. She looked at Greer, not Drummond. If the Clinical Standards Committee finds that I acted within the scope of my training and within the emergency exception provisions of hospital policy, does the incident report close? That would be the standard outcome, yes. And if Drummond continues to characterize my actions as reckless in the interim, does that characterization become part of my permanent file? Greer paused. Whatever enters the record during the review period is part of the administrative case. Sarah looked at the wall above Greer's desk for a moment. There was a framed photograph there, a group shot, some hospital event, maybe 10 years ago. Drummond was in it, standing slightly forward of the group, which told her something about how long this particular arrangement of power had been in place. I'll take the reassignment, she said, under protest, and with a formal written response to the incident report documenting my account of the sequence of events. That's your right, Greer said. Drummond said, That seems reasonable. She looked at him then, really looked at him, in the way she had tried to avoid doing because she knew what it would cost her to see him clearly. He was not a villain. That was the thing about this kind of situation that nobody trained you for. The people who did damage like this were rarely villains. They were people who had been powerful long enough that they had stopped questioning the rightness of their own perspective. They genuinely believed what they were saying. That made it harder, not easier. She stood. Is there anything else? She asked. There wasn't. She wrote the response that evening. 6 pages, single-spaced. Every detail documented in sequence. The initial presentation, the vital sign trend, her clinical assessment, the warning she gave, the order she received, the cardiac arrest, the absence of a credentialed REBOA practitioner, the catheter placement, the hemodynamic response, the OR handoff. She cited her military training records by date and certification number. She cited the hospital's own emergency exception policy, Section 4.3, Paragraph 2. In circumstances where a patient faces imminent death and no licensed specialist is available within the clinical window required to prevent irreversible harm, a trained practitioner may perform a procedure within the scope of their documented competency, provided the action is documented contemporaneously and reviewed at the earliest opportunity. She had read that policy on her first week. She had read every policy in the first week because she had always believed that knowing the rules was the first step toward knowing which ones protected you. She submitted the response through the formal HR process and sent a copy to Greer and kept one for her folder. Then she went to step down for her next shift and did her job. Marcus Tully was ambulatory by the end of the week. She knew this because she passed his room on the way to a patient down the hall, and she glanced through the open door and saw him sitting in the chair beside the bed with a physical therapy aide, working on the mechanics of standing up with a repaired pelvis that still had 60-some screws and plates holding it together. She did not stop. It wasn't her place to stop. She was off the case, off the trauma rotation, and the last thing she needed was Drummond finding out she had been in contact with the patient whose survival was the central fact of the dispute about her conduct. But she saw him, and she registered the fact of him, upright, working, alive. And she carried that fact with her the way she had learned to carry the things that mattered. That evening, walking to her car in the parking structure, she noticed a vehicle she hadn't seen before. A dark SUV with government plates, not Oregon plates, federal plates, parked 2 spots from her usual space. The kind of vehicle that existed in a specific category of institutional infrastructure that she recognized from a life that most of the people inside Hargrove Regional knew nothing about. She stopped and looked at it for a moment. Then she got in her car and drove home. 2 days later, she came to work and found Patricia Greer standing outside the step-down unit with an expression that had moved several categories away from neutral. "We need to talk," Greer said. "What happened?" Greer glanced down the hallway in both directions. "Marcus Tully," she said. "They identified him." Sarah waited. "He's not a bus driver," Greer said. "He's not—" She stopped, started again. "The government plates in the parking structure, that was them. They've been here since yesterday." "Who?" Sarah said. "Who is he?" Greer looked at her. And in that look, Sarah saw something that she had not expected to see. Not fear exactly, but the specific kind of alertness that comes when the weight of something becomes suddenly clear. "He's retired military," Greer said. "High rank. And apparently, he is very well known to some people who are currently sitting in the administrator's conference room asking very specific questions about what happened to him in that trauma bay, and why, and by whose order the physician in charge made the decisions he made." Sarah looked at the window at the end of the hall. Outside, through the glass, she could see the parking lot. The dark SUV was still there, and next to it, a second one. The second SUV had military plates. Sarah stood at the window long enough to register that detail, then turned away from it because standing at windows staring at things was not a productive use of the next 60 seconds. And she had learned a long time ago that the moments immediately after unexpected information arrived were the moments when you most needed to be deliberate about what you did with your hands and your face. "What rank?" she said. Greer blinked. "What?" "You said high rank. What rank?" "I don't—" "They didn't tell me the specific. I think the administrator said colonel or above colonel. I'm not sure about the terminology." Greer pressed her fingers to her temple. "Sarah, I need you to understand that there are people in that conference room who are not hospital personnel and who have been asking for documentation of everything that happened in the trauma bay on December 9th. Every chart entry, every nursing note, the incident report, Drummond's incident report, all of it." Greer looked at her with an expression that had the texture of someone trying to deliver a warning without being explicit enough to be accountable for having warned her. They asked specifically about the nurse who performed the REBOA placement. By name? By action. They knew what had been done before they walked in. They already knew. Greer lowered her voice. "Whoever this man is, someone in his world was paying attention from the moment he came through our doors." Sarah processed this. It was not entirely surprising. There were categories of personnel for whom that kind of institutional surveillance was standard. People whose medical treatment at civilian facilities triggered automatic notifications through channels that most civilians didn't know existed. She had worked adjacent to those channels for 8 years. "Have they asked to speak with me?" she said. "Not yet, but they've asked about you." Greer paused. "They asked about your background." Sarah looked at her. "I told them you were former military," Greer said. "I didn't know what else to say. Is that a problem?" "No," Sarah said. "That's accurate." She walked back to the step-down unit and resumed her shift, and she did it with the particular quality of attention that comes from knowing something is moving toward you without knowing its exact speed. The morning resolved itself in the ordinary way of hospital mornings. Medications administered, dressings changed, a patient in 412 who needed more aggressive pulmonary toilet after his 3rd day of shallow breathing, a family in the hallway outside 408 who had questions that required 20 minutes of careful conversation. Sarah moved through all of it with the same systematic focus she brought to everything, which was not a performance of calm but something more structural, the product of years spent in environments where panic cost more than it bought. At 11:40, a man appeared at the step-down nursing station. He was somewhere in his mid-40s, lean in the specific way of people who have maintained physical conditioning past the point where it was required of them, wearing civilian clothes that fit well enough to look deliberate. He had a visitor badge clipped to his jacket pocket, and the kind of posture that announced military background without announcing it, if you knew what to look for. "I'm looking for Sarah Voss," he said to the ward clerk. The ward clerk looked at Sarah, who was standing 8 feet away updating a chart. Sarah set down the tablet. "That's me." The man looked at her. Something moved across his face. Not recognition exactly, but the thing that precedes recognition, the moment when a description becomes a person. "My name is Garrett Lowe," he said. "I'm with the Department of Defense Inspector General's office. I'd like to speak with you privately if you have a few minutes." She had learned not to answer requests like that with yes immediately. "What's this regarding?" "Marcus Tully," he said. She told the charged nurse she was stepping away for 15 minutes and led Lowe to the family consultation room at the end of the hall. A small room with 3 chairs and a box of tissues on the side table and a window that looked at a brick wall. She sat. He sat across from her. He put a badge on the table between them. She examined it without picking it up. "How long was Colonel Tully in the field?" she asked. Lowe looked at her with the recalibrating expression. "He's not actively classified. His service record is a matter of military record." "I'm not asking about his record. I'm asking how long he was in the field in a capacity that would have someone from the IG's office at a civilian hospital in Caldwell, Oregon, 2 weeks after he came in through the trauma bay." Lowe was quiet for a moment. "You were Army," he said. 8 years. "Forward surgical." "Yes." He nodded slowly, the nod of someone deciding how much lateral they're going to give to the person across from them. Colonel Tully served in 3 combat theaters over 21 years. He retired 14 months ago. He retained an advisory relationship with a DoD program that I'm not at liberty to detail. He paused. His treatment here triggered a notification. "I know how that works," Sarah said. "Then you know why I'm here. You're here because someone in a position of authority over his care made a decision that almost killed him, and you need to understand whether that decision was negligence, incompetence, or something else." Lowe looked at her. He had a face that was professionally neutral but not cold, the face of someone who had developed the ability to listen without reacting, which was a different skill from not caring. "Walk me through December 9th, he said. "Everything." She walked him through it. She did it the way she had documented it, sequentially, specifically, without editorial commentary on Drummond's judgment or her own, just the events in the order they occurred. The initial presentation, the vital signs, her assessment, her warning, the order to step back, the intubation, the arrest, the REBOA placement, the hemodynamic response, the OR. Lowe didn't interrupt. He took notes on a small pad with the particular efficiency of someone who had done a lot of interviews in a lot of difficult circumstances. When she finished, he said, "The incident report characterizes the sequence differently." "I know," she said. "I submitted a formal response." "I've read it." He capped his pen. "The incident report states that your interruption of the clinical team contributed to a delay in the primary physician's management of the cardiac arrest." She looked at him. She understood that he was not saying this as an accusation, but as a fact on the table that required her response. "The incident report is inaccurate," she said. "I have documentation of the sequence. So does the trauma bay's audio log." Lowe went very still. "The trauma bay has audio recording?" "All of Hargrove's trauma bays have integrated audio and video recording for training and liability purposes. It's in the facility documentation. Every trauma activation is logged." "Has that recording been reviewed?" "I don't know," Sarah said. "I'm not on the case. I've been reassigned pending the clinical standards review." Lowe wrote something on his pad. He wrote it in a way that had the quality of importance, the kind of note that was going to become something else later. "One more question," he said. "In your assessment, was Colonel Tully's cardiac arrest preventable?" She looked at the window, at the brick wall outside, at the particular blankness of a surface that offers nothing back. "Yes," she said. "What?" Lowe left the consultation room and did not return, which told her that whatever was happening in the administrator's conference room had just changed shape. She went back to her patients and spent the next 2 hours being a nurse with complete attention, because the situation she was in did not change the fact that the woman in 412 needed her breathing exercises, and the man in 408 needed someone to explain his discharge medications in language his family could understand. At 2 in the afternoon, Drummond walked onto the step-down unit. He was not there to see a patient. He stood at the end of the hallway looking at the nursing station with the specific expression of a man who had recently received information that had reorganized his understanding of his circumstances. His white coat was pristine, his badge was straight, his face was doing significant work. He saw Sarah. He walked toward her. "A moment," he said. She set down what she was holding. "I have a patient I need to get back to in about 5 minutes. This won't take long." He lowered his voice. "There are investigators on this floor." "I'm aware," she said. "They spoke with you." It wasn't a question, but she answered it anyway. "Yes." "What did you tell them?" She looked at him steadily. "I told them what happened." Something shifted in his face. Not quite fear, but the precursor to it. The moment when a man who has operated from a position of unquestioned authority begins to feel the weight of the possibility that the authority is not, in fact, unquestioned. "The incident report accurately reflects the clinical picture as I understood it," he said. "Then you have nothing to be concerned about," she said. He looked at her for a moment longer, and she saw him trying to read her, trying to determine whether she was threatening him or simply stating a fact, whether the steadiness in her face was confidence or performance. She did not help him figure it out. He walked away. The Clinical Standards Committee met in emergency session the following morning. Sarah knew this because Greer told her in a message that was characteristically minimal. "Committee convening 0800. You are not required to attend, but will be notified of outcome by end of day." She worked her shift. She did not attend. At 1:15 p.m., she was paged to the administrator's conference room. She had not been in that room before. It was on the 3rd floor, adjacent to the executive wing, and it had the particular atmosphere of a room that was designed to communicate institutional weight. Long table, upholstered chairs, the hospital's mission statement mounted on the wall in the kind of font that suggested it had been chosen by a committee. There were 6 people in the room when she entered. Patricia Greer, the hospital administrator, a man named Douglas Firth, who she had seen once at a staff all-hands and never spoken to directly. Garrett Lowe from the DoD IG office. 2 people she did not recognize, a woman in her 50s with a federal contractor badge and a younger man with a legal pad. And at the far end of the table, in civilian clothes that could not fully obscure the bearing beneath them, a man she had not expected. He was in his early 60s. Silver-haired, compactly built, with the kind of physical economy that military careers produce in some people and eliminate in others. He had a cup of coffee in front of him that he hadn't touched, and he was watching the door with an expression that changed when Sarah walked through it. He stood up. She stopped. She knew him. Not well. She had seen him twice, maybe 3 times, in circumstances that were not the kind that produced detailed acquaintance. But she knew his face. She knew the rank insignia she had seen on it. She knew the specific way he stood, which was the way of a man who had been in rooms where decisions cost lives and had learned to take up exactly the space he needed and not 1 inch more. Brigadier General Aaron Merritt. Retired now, she realized. He was in civilian clothes, no insignia. But the bearing didn't retire. He looked at her and said, "Sergeant Voss." The room processed this. She saw Firth's expression recalibrate. She saw Greer go very still. "It's just Voss now," she said. "I've been out for 3 years." "I know," he said. "Sit down." She sat. He sat. The room settled. "I'll be direct," Merritt said, which was how she remembered him. "Marcus Tully is a man I served with across 2 theaters. He is also someone who has continued to provide service to this country in ways that I'm not going to detail in this room. When I received notification that he had been treated at this facility and that there were questions about the quality of that treatment, I got on a plane." He looked at Firth, who had the expression of a man who was realizing the meeting he had planned for was not the meeting he was in. "Your chief of trauma surgery," Merritt said, "ignored an intervention by a trained practitioner that might have prevented cardiac arrest. He then filed an official document that misrepresents the sequence of events." "General Merritt," Firth said, I want to assure you that our clinical standards process— I've read your clinical standards process, Merritt said. I've also read the incident report, Dr. Voss's formal response, and the initial assessment filed by Dr. Rao. He paused. I've also listened to the audio recording from the trauma bay. The room went quiet. Mr. Lowe's office requested the recording yesterday afternoon, Merritt continued. The hospital complied within the hour. I listened to it this morning. He looked at Sarah. You warned him. He ignored you. He ordered intubation. The patient arrested. You told them CPR alone wouldn't work. Then you did what needed to be done. Firth said carefully, the clinical standards review is going to find what the recording already shows, Merritt said. What I'm here to discuss is what happens next. What happened next took 3 hours. Sarah was in the room for the first 90 minutes and out of it for the second 90. During the first 90, she answered questions. From Lowe, from the woman with the contractor badge whose name turned out to be Sandra Vreeland and who was some category of DoD legal, from Firth, who had shifted from institutional defensiveness into a more careful mode of operation. Merritt did not ask many questions. He mostly listened, which was, she thought, how he had always operated. He gathered. During the second 90 minutes, she sat in the waiting area outside the conference room and drank bad coffee from the machine down the hall and watched the window at the end of the corridor, which had the same view of the parking lot where the 2 SUVs were still parked. She thought about Drummond. She thought about the way he had looked and stepped down that morning, the reorganized expression, the lowered voice. She thought about the audio recording, which she had known existed and which she had mentioned to Lowe for exactly the reason that it was now being used. She had not manufactured that moment. She had simply known that the record was there, and she had made sure someone with authority knew to look for it. She thought about Marcus Tully in the room down the hall with his repaired pelvis and his daughter named Brielle. She thought about the specific arithmetic of a body in hemorrhagic shock, what it could sustain, what it couldn't, the narrow window between the two. And she thought about the moment the monitor beeped back to life, and she had not exhaled because that was not when you exhaled. She was on her second cup of coffee when Greer came out. They want you back in, Greer said. She went back in. Drummond was there now. She had not seen him come in, but he was sitting at the table. Not at the head, not in his usual institutional position, but to one side, slightly removed from the center of the geometry. He was looking at the table in front of him. Merritt was looking at Sarah. Dr. Drummond has provided a supplemental statement, Merritt said, clarifying certain aspects of the original incident report. Sarah looked at Drummond. He did not look up. The supplemental statement acknowledges that there was a clinical disagreement regarding intubation and that the original report did not fully capture the nursing staff's concern as documented in the audio record. Merritt's voice was the same even, contained voice he had used for the last 3 hours. It does not resolve the question of whether the original report was inaccurate as filed, which is a separate matter that Mr. Lowe's office will pursue independently. Drummond still wasn't looking at anyone. What it does resolve, Merritt continued, looking at Firth, is the question of Sarah Voss's conduct on December 9th. The audio recording, Dr. Rao's statement, and the documented certification records are unambiguous. She performed a procedure she is trained to perform in circumstances that left no viable alternative. The outcome vindicates the decision. The process, whatever its procedural irregularities, does not warrant disciplinary action. Firth said, the Clinical Standards Committee should hear this information before it finalizes any recommendation, Merritt said. That's not a directive. That's a practical observation about what the record contains. Firth nodded. He was a man who understood the landscape of the room he was in. There's one more thing, Merritt said. He looked at Sarah. His expression had something in it now that hadn't been there before. Not warmth exactly, but something adjacent to it. Recognition. The specific kind that carries history. I owe you an explanation, he said, or at least a context. She waited. The 67th Forward Surgical Team, he said. Coringal Valley. September, 7 years ago. The number of people in the room who would have known what that meant without explanation was one. Sarah held very still. I was not there, Merritt said, but I debriefed every survivor. I wrote the after-action report personally. He paused. 18 hours, 1 nurse, 11 patients, 9 of whom made it out alive. He let that sit for a moment. I know what you did there, Voss. I know what you used and what you improvised and what you decided in conditions that would have broken most people with twice your rank. The room had the quality of air before weather changes. I also know, he said quietly, that you never received any formal recognition for it, that the after-action report was classified, that you separated 3 years later without most of the people in this building having any idea who they were hiring. She looked at the table. I'm not here to fix that, he said. That's not in my power anymore. What I'm here to do is make sure that what happened in that trauma bay on December 9th is understood correctly, and I think we've accomplished that. He looked at Firth. My office will remain in contact with yours throughout the remaining review process, he said. It wasn't a threat. It was simply a statement about what was going to happen. Firth said, Of course. She walked out of that room at 4:47 in the afternoon into a corridor that looked exactly like it had looked that morning. The same institutional carpet, the same overhead lighting, the same sound of hospital equipment and distant voices. And everything about it felt different in the specific way that things feel different after the weight that has been pressing on them has been partly redistributed. Partly. Not fully. The clinical standards review was still open. Drummond was still in that building. The incident report was still in the system. She walked to the stairwell because she needed stairs rather than elevators. The physical act of climbing something, even 3 flights, even in a hospital stairwell that smelled of cleaning fluid and recycled air. At the second-floor landing, she stopped because Mia Sutton was sitting on the stairs. The second-year resident was still in her scrubs from what had clearly been a very long shift, and she had the particular defeated posture of someone who has been carrying something for too long in too small a space. I heard Merritt was here, Sutton said. Yes, Sarah said. I heard they have the audio. Yes. Sutton was quiet for a moment. She was young, 28, maybe 29, and she had the kind of intelligence that had probably made most things in her life feel navigable until she had stood in a trauma bay and watched a man go into cardiac arrest after an intervention she had privately known was wrong, and then found herself choosing, in the next 20 seconds, whether to move to the bedside of the nurse doing the thing that needed doing. She had moved. Sarah had seen it. I need to give a statement, Sutton said. To Lowe's office. They contacted me this afternoon. Okay, Sarah said. I don't know what to say. Say what happened, Sarah said. In sequence. What you saw, what you did, what you heard. Don't characterize it. Just say the events. Sutton looked up at her. Drummond is going to know I talked. He's going to know regardless, Sarah said. The audio exists. Your actions are already part of the record. That's not exactly comforting. I know, Sarah said, but the alternative is giving a statement that doesn't match the recording, and that's worse. Sutton was quiet. Sarah sat down on the step above her because this conversation required more than passing through, and she had learned that the particular calculus of what a younger person needed from someone older sometimes required the physical fact of staying. What was it like? Sutton said. In the field, when there was no chain of command to defer to. Sarah thought about how to answer that. There was always a chain of command, she said. The question was just whether the person at the top of it was making decisions that preserved life or didn't. When they weren't, you had to decide whether the chain of command was the thing you were protecting or whether the patient was. And you always chose the patient. Not always, Sarah said, but December 9th, yes. Sutton nodded slowly. Then she said something that Sarah had not expected. I should have said something. When he ordered intubation, I knew you were right. I could see it in the numbers, and I didn't say anything. Sarah looked at the stairwell wall, at the institutional paint slightly yellowed at the edges. You moved to the bedside, she said, when it mattered. That's not the same as speaking up. No, Sarah said. It's not, but it's what you did. You can decide what you do next. Sutton was quiet for another moment. Then she stood up. She pulled her scrub top straight and looked at Sarah with the expression of someone who has made a decision they're going to have to live with. I'll give the statement tomorrow, she said. She went up the stairs. Sarah watched her go. No. The next morning started normally. Or it appeared to start normally, which is the way mornings announce themselves before they become something else. Sarah arrived at 6:50, signed in, and was told by the ward clerk that she had been temporarily reassigned back to the trauma wing pending the committee's interim review. Not a full restoration, but a partial one, an acknowledgement that the situation had shifted. She changed her assignment and went to the trauma wing briefing, where she took her place at the table among the team she had been removed from for 2 weeks. Nobody said anything directly, but Reed Horton, the third-year attending who had ordered the reassessment in room 417 days ago, looked at her across the table when she sat down and gave her a single nod, the kind that didn't require language. The briefing was routine. The board was full but not catastrophic. 3 post-operative monitoring cases, 1 overnight admission with unclear presentation, 2 anticipated transfers from the ICU. She was assigned bays 2 and 3. She went to work. At 9:15, the trauma activation page went off. Single patient, motor vehicle versus pedestrian. ETA 8 minutes. She was in bay 2 when Drummond walked past. He did not look at her. He walked to the trauma bay with his coat straight and his badge visible, and the particular posture of a man who was performing normalcy under conditions that required significant effort. She finished her patient and moved to support position for the incoming trauma, which was her assignment. The patient arrived at 9:24. Middle-aged woman. Leg fracture, possible internal. Pressure adequate. She was frightened and in pain, and she kept asking about her dog, whether her dog had been at the scene, whether someone had checked on her dog. Sarah held her hand while the assessment ran. "We'll find out about the dog," she said. "Right now I need you to focus on your breathing. Is she okay?" "We're going to find out. Breathe for me." The woman breathed. The trauma team worked around her with the organized efficiency of a team that had done this many times, and Drummond led the assessment with technical competence that was genuinely real. Whatever he was as a political entity, as a physician in this specific context, he knew what he was doing, and the woman was stabilized and moved toward imaging within 19 minutes. Sarah was updating the chart when she heard it. Not a sound from the trauma bay, a sound from down the hall. Voices, more than one, the particular quality of conversation that had weight and direction. She looked up. 2 men she hadn't seen before were walking toward the nursing station. Not low. Different bearing, younger, military, and in uniform this time. Army service uniforms, the kind worn for formal occasions. Behind them, at a pace that was neither fast nor slow, was Merritt. And behind Merritt was a 4th person she had not seen before. A man in his late 50s, uniformed, with the rank insignia of a major general. 2 stars. He was someone who did not need to walk quickly because the space in front of him tended to clear. They stopped at the nursing station. The major general looked at the charge nurse and said, "I'm looking for the nurse who pulled Marcus Tully back." The charge nurse, a 20-year veteran named Rosario, who had weathered considerable in her career, looked at the major general without visible awe and said, "Can I ask who's asking?" "Major General Douglas Farr," he said. "I knew Tully for 30 years. He paused. "I'd like to speak with her." Rosario looked at Sarah. Sarah walked over. Farr looked at her the way Merritt had looked at her in the conference room, the look of a description becoming a person. He extended his hand. "They told me what you did," he said. "I did what was indicated," she said. "Is that what you call it?" She shook his hand. "The general tells me," Farr said, angling his head toward Merritt, "that you served with the 67th, that you were in Korengal in September." "Yes," she said. He nodded. He looked at her for a moment with an expression that was more complex than admiration. It had grief in it, and relief, and the particular weight of someone who had spent years thinking about a set of events from a distance and was now standing close to one of its facts. 11 patients, he said. 9 made it out, she said. 9, he repeated. The word had a different texture when he said it. She nodded. I lost one of them anyway, she said. 6 months later. Complications. She kept her voice level. I know you know that. It's in the after action. I know, he said. It was not your fault. I know that too, she said. It doesn't change what it felt like. He looked at her for a moment. Then he said, The committee is meeting this afternoon. I understand there are documentation issues with the original incident report. That's under review, she said carefully. The recording has been submitted to the committee, Merritt said from slightly behind Farr. Lowe's office submitted Sutton's statement this morning. Sarah looked at him. She went in at 7 a.m., Merritt said, before her shift. Something moved in Sarah's chest that she kept off her face. Farr said, "What Drummond filed is being addressed through the appropriate process," Sarah said. "I trust the committee will review the full record." Farr looked at her for a moment, reading something in the answer. "You trust the process," he said. It wasn't exactly a question. "I trust the record," she said. "The process follows the record." He looked at Merritt. Merritt looked at Farr. Something passed between them that she was not entirely meant to see but was not entirely excluded from. Then Farr said, "There's something you should know before the committee meets." She waited. "The documentation issue," he said. "Lowe's office ran a comparison this morning. The incident report is filed against the raw data in the hospital's event logging system." He paused. "The timestamps don't match." Sarah went very still. "The original incident report records the sequence with your REBOA placement occurring before the cardiac arrest," Farr said. "The event log shows the arrest occurring 4 minutes and 11 seconds before your intervention." She understood what that meant. The incident report didn't just characterize her actions uncharitably. It had reversed the sequence. It had made her intervention look like a cause rather than a response. "That's not a documentation error," she said. "No," Farr said. "It is not." The corridor was very quiet. She looked down the hall toward the trauma bay, where Drummond was currently finishing a post-assessment note, where he would remain for the rest of the morning in the practiced normalcy of a man who had not yet been told that the ground beneath him had changed composition in the last 12 hours. She looked back at Farr. "When does the committee meet?" she said. 2 o'clock, Merritt said. She checked the clock on the wall. It was 9:51 in the morning, 4 hours. "I have patients until noon," she said. Farr nodded. "We'll be there." She went back to work. She was in the middle of a vital signs check at 11:30 when Rosario appeared at her elbow and said quietly, "Drummond's been called to the administrator's office." Sarah kept her eyes on the monitor. "When?" 15 minutes ago. He hasn't come back." She updated the chart. She finished the check. She moved on to the next patient with the same systematic attention she had brought to every patient in every shift for the last 23 days. And she did not allow herself to think about what was happening on the 3rd floor, or what Drummond's face looked like when someone put a timestamp comparison in front of him, or the specific quality of silence that falls on a man in the moment he realizes that the story he told has been measured against the record and found to be something other than what happened. At 1:55, she changed out of her scrubs in the locker room, put on the clean set she kept in her bag for administrative meetings, and took the stairs to the 3rd floor. The conference room door was closed when she arrived. She sat in the waiting chair outside. At 2:03, the door opened and Garrett Lowe came out. He looked at her with an expression that had moved past professional neutrality into something she could not quite name. "They're ready for you," he said. She stood. "Drummond's in there," Lowe said. "He came with a lawyer." She looked at the closed door. "Anything I should know?" she said. Lowe considered this for a moment with the expression of a man deciding what he was permitted to say. "The committee has the timestamp comparison," he said. "They have the audio. They have Sutton's statement and Rao's statement and your formal response." He paused. "They also have something else that came in an hour ago." She waited. "A second incident report," Lowe said, "filed by Drummond. This one is about Sutton. He's claiming she violated chain of command by assisting you without physician authorization." Sarah looked at him. "He filed it this morning," Lowe said, "after he was summoned to the administrator's office, before the committee meeting." She understood what that was. It was a move. Not a strong one. The timing made it transparent, the same way a man who reaches for something when he's cornered telegraphs exactly what he's afraid of. But it was aimed at Sutton, who was 28 years old and in the 2nd year of a residency that could be derailed by exactly this kind of institutional pressure. She looked at the door. "Sutton's statement is already in the record," she said. "Yes," Lowe said. "The committee will see the timing." "Yes," he said again. She put her hand on the door. She pushed it open. The room was fuller than it had been before. The committee, 5 physicians and 2 administrators, sat along one side of the table. Firth at the far end. Merritt and Farr to one side, observer status. Sutton was there, which Sarah had not expected. The young resident was sitting very straight with her hands on the table and the expression of someone who had decided something and was staying decided. And at the near end, with a man in a suit beside him who had the unmistakable presentation of legal counsel, was Drummond. He looked up when she came in. He looked older than he had that morning. Not dramatically, nothing in his appearance had changed, but something in the way his face was carrying itself had shifted. The weight of the morning had settled somewhere behind his eyes in a way that changed their quality. She sat down across from him. The committee chair, Dr. Anita Horowitz, a hospitalist Sarah had never spoken to, looked at both of them and said, "We're going to proceed through the record in sequence. I'd ask everyone to hold questions until we've established the documented timeline." She opened the folder in front of her. "December 9th, she said, Trauma Bay 1, Hargrove Regional Medical Center, 7:19 a.m. The room went quiet. Drummond's lawyer leaned over and said something in his ear. Drummond shook his head once, sharply, and the lawyer sat back. Horowitz looked at the folder. She looked at the timestamp comparison. She looked up at the room over her reading glasses. "I'm going to begin," she said, "with the event log." The event log ran to 11 pages. Horowitz read the relevant section aloud without editorializing, which was the correct approach, and which Sarah recognized as the mark of someone who understood that the document itself was the argument. The timestamps were precise to the second, the kind of precision that exists in automated systems because automated systems do not have institutional relationships or career incentives or the particular human need to be on the right side of a difficult morning. 7:19:04. Trauma activation. Patient received. 7:23:17. First nursing assessment note entered. Vital signs documented. Blood pressure 74 systolic. 7:24:52. Second nursing note. Clinical concern flagged. Pelvic instability. Retroperitoneal hemorrhage suspected. Warning regarding intubation risk in hypotensive patient. 7:26:08. Physician order entered. RSI protocol initiated. 7:27:41. Blood pressure 41 systolic. Trending critical. 7:28:19. ECG flatline documented. 7:28:19 to 7:32:30. CPR in progress. No restoration of spontaneous circulation. 7:32:38. REBOA placement initiated. 7:34:44. Return of spontaneous circulation documented. Blood pressure 39 systolic ascending. Horowitz looked up from the document. The room was quiet in a way that had texture to it. She set the event log aside and picked up the incident report. The one Drummond had filed. The one that had initiated Sarah's suspension from the trauma rotation. She did not read it aloud. She read a single line from it, and she read it in the same even, unhurried voice she had used for the timestamps. The incident report states, and I quote, "The nursing staff's unauthorized intervention preceded the physician's clinical management and introduced significant confusion into the resuscitation sequence." She set it down. The event log documents the patient's cardiac arrest at 7:28:19. It documents the nursing intervention at 7:32:31. That is a gap of 4 minutes and 12 seconds. She looked at the table. The nursing intervention did not precede the resuscitation. It followed 4 minutes of failed resuscitation. Drummond's lawyer put his hand on the table. Drummond put his hand over the lawyer's and the lawyer went still. The report also states, Horowitz continued, picking up a second document, the annotated comparison that Lowe's office had compiled, that the patient's cardiac arrest occurred, quote, in the context of the clinical disruption caused by nursing staff. The event log records the RSI order at 7:26:08 and the flatline at 7:28:19. The nursing staff's primary documented intervention prior to the arrest was a warning against intubation, entered at 7:24:52. She set the document down. "A warning," she said, "not a disruption. A warning." Drummond's lawyer asked to make a statement. Horowitz allowed it. The lawyer was a trim, precise man named Aldrich, who had the particular quality of someone whose competence was real, but whose position, this morning, had the architecture of a building in which something structural had already failed. He spoke for 7 minutes. He covered clinical complexity, the pressure environment of a live trauma, the reasonable interpretation of sequence by an attending physician operating in real time, the documented history of nursing staff exceeding scope in high acuity environments. He did not address the timestamps directly. When he finished, Horowitz said, "Does the committee have questions for Dr. Drummond?" There was a pause. Then Dr. Raymond Osei, the trauma surgery representative on the committee, a man Sarah recognized from the department board roster but had never spoken to, leaned forward. "Dr. Drummond," he said, "the nursing note at 7/24/52 documents a specific clinical concern about intubation in a hypotensive patient with suspected pelvic ring disruption. It also documents your response." He looked at the document in front of him. "The audio recording confirms this exchange. My question is straightforward. At the time you ordered RSI, were you aware of the nurse's concern regarding induction-related vasodilatation in a patient with hemorrhagic shock at this level of hypotension?" The room waited. Drummond said, "I was aware of a concern being raised." "And you proceeded with intubation." "The patient required airway management." "The patient's blood pressure at the time of your order was 74 systolic," Osei said. "Common induction agents, ketamine, propofol, succinylcholine, all carry vasodilatation risk in a hemodynamically compromised patient. The concern was clinically founded." "Clinical decisions in a live trauma are made with incomplete information under time pressure," Drummond said. The protocol doesn't mandate intubation at that blood pressure in a patient with suspected pelvic hemorrhage," Osei said. He said it quietly. "That was a judgment call. And the record shows that a nurse with documented expertise in exactly this presentation told you the consequence before it happened." He looked at Drummond. "And 4 minutes and 11 seconds later, that consequence occurred exactly as she predicted." Drummond looked at the table. His lawyer put his pen down. The committee took a recess at 3:15. Sarah waited in the corridor again, this time with Sutton beside her. The young resident was holding a paper cup of water that she wasn't drinking, and she had the look of someone who had been carrying a weight for weeks and was now waiting to find out whether putting it down was going to cost her anything. "The second incident report," Sutton said. "The committee has it," Sarah said. "The timing is pretty obvious." "Yes." Sutton turned the cup in her hands. "He knows I gave the statement." "He knew before you gave it," Sarah said. "That's why he filed it." "Is that supposed to make me feel better?" "No," Sarah said. "It's just true." Sutton was quiet for a moment. Then, "Do you ever feel like the people who follow the rules are the ones who pay for it?" Sarah thought about how to answer that honestly. "Sometimes," she said. "But usually what I've seen is that the people who change the rules to protect themselves eventually run out of room. The record gets long enough that there's nowhere to hide in it." "You sound very certain about that." "I'm not certain," Sarah said. "I've just watched it enough times to think it's more likely than not." Sutton looked at the conference room door. "What happens to me if the committee—" "The second incident report doesn't have a factual basis," Sarah said. "You provided nursing assistance to a practitioner performing an emergency procedure. The event log puts your action after the arrest, after the REBOA placement began. There is no chain of command to violate after the attending physician has left the decision space." Sutton absorbed this. "Your statement is corroborated by the audio," Sarah said. "His report isn't corroborated by anything except his previous report, which has already been contradicted by the timestamps." She looked at the young resident. "Give your testimony when they call you back in. Say what happened, in sequence." Sutton nodded. "Once. The nod of someone who had made the decision and was staying made." The committee reconvened at 3:42. They called Sutton first. Sarah waited outside. Sutton was in the room for 26 minutes. When she came out, her expression was composed in the effortful way of someone who has been through something and is making sure that whatever they're carrying doesn't show in their face yet. She sat in the chair next to Sarah and let out a long, controlled breath. "They asked about the second incident report," she said. "What did you say?" "I said I was unaware of it, and then they told me when it was filed." She paused. "And then they asked Drummond's lawyer to explain the timing." Sarah waited. "He said it was filed in response to a pattern of conduct that had only recently become clear." Sutton's voice was careful. "And then Dr. Horowitz asked whether the pattern predated December 9th and whether it had been documented anywhere before the report was filed this morning." She looked at her hands, and the answer was no. Sarah said nothing. "And then," Sutton said, "General Merritt asked to speak." She glanced at Sarah with an expression that was still processing what it had witnessed. He doesn't waste words. No, Sarah said. He doesn't. No. They called Sarah back in at 4:09. The atmosphere in the room had changed. Not dramatically. It was the same chairs, the same table, the same afternoon light coming through the window at an angle that was flattening. But the geometry of who was carrying weight had shifted. Drummond's lawyer was sitting back now, the angle of withdrawal. Drummond himself had his hands on the table in front of him, and his face in the arrangement of a man who has been through something that has reorganized his understanding of where he stands. Horowitz looked at Sarah. We have reviewed the event log, the audio recording, Dr. Rao's clinical statement, Dr. Sutton's statement, your formal response to the incident report, and your credentialing documentation. She paused. We have also reviewed the secondary incident report filed this morning against Dr. Sutton and the timeline of its filing. Sarah waited. The committee has a specific question, Horowitz said. The hospital's emergency exception policy, section 4.3. Were you aware of that policy when you performed the REBOA placement? Yes, Sarah said. Walk me through your reasoning at the time. She did. She kept it clinical. The blood pressure, the timing, the absence of a credentialed specialist in the window available, her documented certification, the documented failure of CPR to restore circulation, the patient's imminent death as the only certain outcome of inaction. She did not editorialize. She did not reference Drummond by name in her account of the sequence. She stated events. When she finished, Osei said, Section 4.3 requires that the practitioner have documented competency for the procedure performed. Your military certification was current at the time? Recertified 18 months prior, she said, through the Advanced Trauma Life Support Continuation Program, military track. The certification is in my credentialing file. The committee has reviewed it, Horowitz said. Osei said, no further questions. Horowitz looked at the rest of the committee. No one spoke. Thank you, Ms. Voss, Horowitz said. We'll notify you of the committee's finding by end of business today. Sarah stood. She looked at the room, at Merritt, who gave her nothing, which was what she needed from him in this moment, at Farr, who looked at her with the expression of a man who had watched something get confirmed that he already knew, at Drummond, who was looking at the table. She walked out. The notification came at 6:18 p.m. A digital message to her employee portal from the Clinical Standards Committee, formal header, case number, the precise language of institutional finding. She read it once. Then she read it again. The committee found, unanimously, that Sarah Voss's actions on December 9th fell within the scope of Hargrove Regional Medical Center's Emergency Exception Policy, Section 4.3, and were consistent with her documented clinical competency. Her suspension from trauma department privileges was lifted effective immediately. The incident report was formally closed with a finding of no violation. The committee further found that the original incident report contained documentation inconsistent with the facility's automated event log, specifically regarding the sequence of events preceding and following the patient's cardiac arrest. This inconsistency was referred to the hospital's Quality and Patient Safety Department for independent investigation. The secondary incident report, filed against Dr. Mia Sutton, was dismissed on the grounds of insufficient factual basis. She sat in the break room where she had read the first notification of the incident report, the same chair, the same view of the same wall, and she read the finding a third time. Then she put her phone in her pocket and finished the remainder of her coffee, which had gone cold, and she thought about the sequence of things and what came next. What came next began the following morning. Drummond came to work. This was not a surprise. His administrative status had not been formally altered by the committee finding, which addressed Sarah's conduct rather than his own. What the committee had done was refer the documentation inconsistency to Quality and Patient Safety, which was a different process with a different timeline and a different set of consequences. That process had not concluded. He was still, formally, Chief of Trauma Surgery. He came to work in the way of a man who has decided that forward motion is the correct response to a difficult position. He did the briefing. He reviewed the board. He moved through the morning with professional competence that was real, because his competence had always been real. It was the other thing that had failed. Sarah was back in the trauma wing. She worked her assignment. She did not avoid him, but she did not seek him out. They were in the same space for most of the morning, and they spoke twice, once about a shared patient, once about supply positioning near the trauma bay cabinet, and both times the exchange was brief and clinical and contained. It was Rosario who told her at 11:15 that a meeting had been scheduled for 2 p.m. in Firth's office, not the conference room, the administrator's office, which was a smaller room with a different set of institutional implications. "Who's in it?" Sarah asked. "Drummond, Firth, hospital legal, Lowe." Rosario paused. "And Merritt." Sarah noted this. She went back to her patient. At 1:50, she was in the medication prep room when Drummond came in. She had not expected this. She kept her attention on what she was doing. He stood near the door for a moment. Then he said, "I need to speak with you." She finished the prep. She turned around. He looked not diminished, exactly. That was not the right word. He looked like a man who had been in a significant accident and was standing up, which was different from being fine. The authority was still there in his bearing, the decades of institutional position that didn't disappear because a committee had found against you. But something underneath it had shifted. "The meeting at 2, he said. "I know about it," she said. "You're not in it." "I know that too." He looked at her. He seemed to be deciding something. Or perhaps he had already decided and was simply gathering the capacity to say it. She had seen this before in commanding officers who had made a mistake significant enough to require acknowledgement. Some of them could do it. Some of them could not. "I ignored a clinically sound warning," he said. "The patient paid for it." She said nothing. "That's what happened. That's the factual account." He was not looking for absolution. She could hear that in the quality of his voice. He was stating something that he had been carrying since 7/28 on December 9th, and that he was now, in this small medication prep room, putting down in the only form available to him. "The report characterized the sequence incorrectly. I know how it happened. I'm not going to explain it to you." "You don't need to," she said. He looked at her. "I know." She picked up the medication tray. "I have a patient," she said. He moved aside. She walked out. She did not look back, not because she was performing anything, but because there was nothing behind her that required her attention. The patient in Bay 3 required her attention. The patient's medication timing required her attention. The work was what was in front of her, and the work was what she went back to. The 2 p.m. meeting lasted 40 minutes. She heard the outcome from Greer, who came to find her in the trauma wing at 4:30 with the expression of someone delivering news that is significant and that they have been rehearsing how to deliver. "Drummond is stepping down as chief of trauma surgery," Greer said, "effective end of the month. The hospital is characterizing it as a voluntary transition." Sarah kept her eyes on the chart she was updating. "And the quality and patient safety investigation?" "Still running. The DoD IG referral means it's not entirely internal anymore. That process will run separately, and Drummond doesn't control the outcome." Greer paused. "The documentation issue. If QPS confirms what the committee found, it goes to the state medical board." Sarah looked up. "That's not guaranteed," Greer said carefully, "but it's in the process." "Sutton?" "The secondary report is gone. Dismissed, expunged from the file. Firth personally called her department chief." Greer paused. "She'll be fine." Sarah turned back to the chart. "Good," she said. Greer stood in the bay entrance for a moment longer. "Are you all right?" Sarah thought about that question and the various things it was actually asking. "I'm working," she said. Greer nodded. She understood that this was the answer. Marcus Tully was discharged on a Thursday. Sarah knew this because Deborah told her, and because she was on shift when the discharge paperwork processed, and because she happened to be walking toward the elevator when the hospital transport aide was wheeling him through the corridor toward the exit. He was in a wheelchair. Hospital protocol for discharge regardless of ambulatory status, and his ambulatory status was still limited. He had a Velcro boot on his left foot, and the careful posture of a man whose pelvis had been reconstructed from pieces, and who was now relearning how his body moved through space. His daughter was beside him. She was 7 years old and wearing a red coat that was slightly too large for her, and she had her hand on the arm of the wheelchair in the specific way of a child who needs to be touching the person she was afraid of losing. She was telling him something. Sarah couldn't hear the words, but the cadence was the story. The steady stream of a child catching a parent up on all the things that had happened while he was away. He was listening with his whole attention, the way parents listen when they have been away somewhere, and the listening itself is a form of recovery. Sarah stopped at the wall and let them pass. Tully looked up as the wheelchair rolled past her. He didn't know who she was. She was a nurse in scrubs in a hospital hallway, one of dozens he had seen over the past 2 weeks. He had no reason to connect her face to what had happened in the trauma bay. He had been unconscious, technically dead, for the relevant portion of it. He gave her the small nod that patients give hospital staff as a general courtesy. She gave it back. The wheelchair moved past. She watched them go, the man and his daughter, and the red coat and the story the girl was telling, and she felt something settle in her chest that was not quite resolution and not quite grief, but the specific mixture of both that comes from having done a thing that mattered in a way that will never be publicly attributable to you, and making your peace with that. She went back to work. 3 days after Tully's discharge, the quality and patient safety report was complete. It was not a short document. She received a summary through Greer. The full report went to Firth and Hospital Legal in Lowe's office, and through Lowe to channels she was not directly connected to. The summary was 4 paragraphs. She read it in the break room in the 9 minutes between a patient transfer and an incoming trauma assessment. The QPS investigation confirmed the timestamp discrepancy. It confirmed that the incident report as originally filed materially misrepresented the sequence of events in a way that shifted responsibility for the cardiac arrest from the clinical decision that preceded it to the intervention that followed it. The investigation characterized this as a documentation error that, given its systematic and self-serving nature, could not be attributed to inadvertence. The report was forwarded to the Oregon State Medical Board. She folded the summary. She put it in her pocket. She went to the incoming trauma assessment. Well, the Oregon State Medical Board notification came 6 days after the QPS referral. She did not receive this directly. It was not her proceeding. What she received was a call from Garrett Lowe, who had the manner of a man tying off the last threads of something he had been working carefully for several weeks. The board opened a formal review, he said. Drummond's license is active pending outcome. The review process runs 3 to 6 months, typically. What's the likely finding? She said. I'm not in a position to predict medical board findings. What's the documented basis for the referral? Falsification of a medical record, Lowe said, which in Oregon carries mandatory review, and in cases with patient harm in the causal chain, significant disciplinary weight. She understood what that meant without requiring him to be more specific. One more thing, Lowe said. Merritt asked me to pass something along. A pause. He said, the after action from Korengal is being declassified, partial declassification, the section relevant to the nursing team's actions during the attack. Sarah was quiet for a moment. He said you'd know what that meant, Lowe said. She did. It meant that the thing she had done in a tent in the Korengal Valley with a headlamp and 2 units of blood and 11 men who needed her to be someone she wasn't sure she was yet. That thing was no longer going to exist only in classified documents that nobody at Hargrove Regional had ever been allowed to read. It was going to be part of the record in a form that could be spoken about. She didn't know how she felt about that. It was a complicated thing to have something you had kept private for 7 years become something other than private. She had not asked for it to happen. She was not sure she would have asked for it if the option had been presented to her, because the thing itself, the tent, the headlamp, the decisions made in the dark, existed in a part of her that she had learned to leave alone. But Merritt had done it, and she understood why, and she was not going to pretend she had no response to it. Tell him thank you, she said. I will, Lowe said. She hung up and stood in the break room with the phone in her hand for a moment longer than she usually allowed herself to stand still. Then her pager went off. She put the phone in her pocket and went. 2 weeks after Drummond formally vacated the chief of trauma surgery position, Firth called Sarah to his office. It was a different kind of meeting from the ones before. No lawyers, no committee, no government badges on the table. Just Firth behind his desk with a folder in front of him, and the particular quality of attention he gave to conversations he considered important. He told her that the department was conducting a formal search for Drummond's replacement. He told her that the search committee had been assembled and that the interim chief, Dr. Osei, who had been on the clinical standards committee, had agreed to serve in that role during the transition. He told her these things, and then he told her something else. We're redesigning the trauma department's protocol structure, he said, specifically the emergency exception provisions and the escalation pathway when a clinical disagreement exists between nursing staff and the attending of record. He paused. I'd like you to be involved in that process. She looked at him. In what capacity? Advisory. We're calling it the Trauma Integration Working Group. 4 physicians, 3 nurses, 1 DoD liaison. He paused. Lowe's office suggested the liaison position, given the circumstances. Lowe suggested me for this? Lowe suggested the liaison position. I'm asking you whether you want to be in the room. Firth looked at her with the directness of a man who has recently had a significant education in the cost of not paying attention to the right things. You were right, Voss, about the patient, about the sequence, about what the record would show. I didn't know who you were when you came through that door 3 months ago, and I should have found out. She absorbed this. I'm not offering you a promotion, he said. That's not what this is. The working group meets monthly. It's an advisory function. I know what advisory means, she said. He nodded. He pushed the folder toward her. Inside was a single page. The working group charter, drafted in the neutral language of institutional process, but readable if you understood the context as a document about what happens when hierarchy operates without accountability, and the consequences of that decision arrive at 74 systolic on a December morning. She picked it up. She read it. It was not perfect. No document like this was ever perfect. The language was careful in the way of things written by committees, and there were provisions that would require significant implementation work to mean what they were supposed to mean, and the real test of it would be in the moments when someone used it in a live trauma situation and the room had to decide whether the document actually held. But it was a start. She looked at Firth. I'm in, she said. He nodded. The first meeting is Thursday. She stood. She was nearly to the door when he said, Voss? She turned. The after action from Korengal, he said. I read the declassified section. She waited. The hospital is going to post a formal acknowledgement, he said. Not a press release, an internal communication to the staff. What you did there and what you did here. He paused. I want you to know before it goes out. She looked at him for a moment. She thought about what to say, and she thought about the tent and the headlamp and the 11 men and the 9 who made it out and the 2 who didn't, the one who died at the scene and the one who died 6 months later from complications she had reviewed in the after-action report until she could recite them in her sleep. The 2 who didn't make it, she said. Make sure that's in there too. Firth looked at her. If you're going to post something about what happened, she said, include all of it, not just the part that reflects well. He was quiet for a moment. Then he said, All right. She walked out. In the corridor, she passed Reed Horton, who was coming from the briefing room with a coffee in each hand, and the look of someone who had been working since 6 and was not going to stop until 8. He stopped when he saw her. Working group, he said. He had apparently heard already, which was how hospitals worked. Yes, she said. Good, he said. And then he kept walking, because there was nothing more that needed to be said between 2 people who understood each other's work, and the coffee was getting cold. She was halfway to the trauma wing when her phone buzzed. An internal message, sender listed as the medical staff office. She opened it. It was a notification of a formal complaint filed with the Clinical Standards Committee. Not against her. Against Drummond. A separate complaint filed not by the QPS office, not by Lowe, not by anyone connected to December 9th. It was filed by a patient. She read the complainant information. A man named Peter Aldridge, admitted 14 months ago, before she had ever set foot in Hargrove Regional. It was alleging that a clinical warning had been ignored during his trauma treatment and that the resulting delay had contributed to a surgical complication that had cost him the function of his left hand. She stood in the corridor and read the filing date on the complaint. It had been submitted 4 days ago. After Drummond's name had appeared in the internal communication about his role in the December 9th incident, a communication that had gone to all medical staff per Firth's decision as part of the transparency process the working group charter required. She understood what she was looking at. Aldridge had seen Drummond's name in the internal communication. Aldridge had recognized it, and Aldridge had filed a complaint that had apparently been sitting somewhere in his consideration for 14 months, waiting for the moment when filing it felt like something other than futile. This was not the only one. She understood that with a certainty that was not prescience but pattern recognition, the specific clarity that comes from knowing how these things worked. When the first complaint became public enough to matter, the others followed. That was how institutional accountability worked when it worked at all. The first person who filed was the person who made it possible for everyone who came after. December 9th had been the first. Peter Aldridge's hand was what came after. She put the phone in her pocket. She walked to the trauma wing. She went to work. The Peter Aldridge complaint did not stay quiet. That was the nature of these things. Once a document entered the formal system, the system generated its own momentum, and by the following Monday, the medical staff office had received 2 additional complaints referencing Drummond by name. Both were former patients. Both cited incidents that predated December 9th by more than a year. Both had the particular quality of accounts that had been held privately for a long time and were now being released into a process that had finally demonstrated it might actually do something with them. Sarah learned this from Rosario, who learned it from the ward clerk in the medical staff office, who was not supposed to share that information, but who existed in the same human ecosystem as everyone else in the building and who understood that some information moves because people need it to move. She did not seek out the details. She had her own work, but she registered the pattern because the pattern mattered. The Trauma Integration Working Group met for the first time on a Thursday morning in the small conference room adjacent to the trauma wing, not the executive conference room on the 3rd floor, which was the room of formal institutional weight, but a working room with a whiteboard and a table that had seen better decades and chairs that didn't all match. Osei had chosen the room, and Sarah appreciated the choice because it communicated something about what this process was supposed to be. There were 8 people at the table, 4 physicians, including Osei, 3 nurses, including Sarah and Rosario, and Garrett Lowe, who had apparently agreed to serve as the DoD liaison in a personal capacity that was slightly outside his normal IG role, but which Merritt had apparently facilitated through channels that Sarah did not ask about. Osei opened the meeting by putting a single document on the table, the existing emergency exception policy, section 4.3, with 3 sections highlighted in yellow. These are the gaps, he said. The policy allows emergency exception. It does not define the escalation pathway when the attending of record is the source of the clinical risk. It does not define documentation requirements in real time during the exception. And it does not define accountability for the physician whose decision creates the emergency condition the exception is responding to. He looked at the table. December 9th exposed all 3 gaps simultaneously. There was a silence in which everyone present processed the fact that they were sitting in a room whose existence was the direct result of one morning and one patient and one nurse who had reached for a cabinet when the alternative was watching someone die. "So," Osei said, "let's fill them?" They worked for 2 hours. It was not smooth. Nothing like this was smooth because the people in the room had different training backgrounds and different institutional priorities and different threshold tolerances for the specificity of language and policy documents. And the gaps between those things had to be navigated in real time by people who were also tired and also had patients waiting for them. Rosario pushed back on a provision that she thought gave too much discretionary authority to the attending in the escalation pathway. Lowe asked 3 questions about documentation standards that were so precise they forced the physicians in the room to be more precise themselves. A 3rd-year physician named Harland wanted to add a provision that Sarah thought was well-intentioned but would create ambiguity in the exact scenario it was meant to address, and she said so directly, and Harlan pushed back, and they went back and forth for 11 minutes until Osei drew a diagram on the whiteboard that resolved the disagreement by showing both of them what the provision actually said versus what they each thought it said. It was the kind of work that looked like nothing from the outside and was everything from the inside. At the end of the 2 hours, they had a revised draft of Section 4.3 that addressed 2 of the 3 gaps and had a framework for the 3rd that needed another meeting to finalize. It was incomplete. It was a start. Sarah drove home that evening feeling something she had difficulty naming for the first few miles and then named it usefulness. Not the acute usefulness of a procedure performed under pressure, but the slower, more durable usefulness of changing the conditions so that the pressure arrived in a different shape next time. She had spent 8 years doing the acute version. She was learning, apparently, how to do the other one. The Oregon State Medical Board issued its preliminary findings 6 weeks after the referral. She did not receive this directly. What she received was a message from Firth, brief, 3 sentences, informing her that the board's preliminary finding had been issued and that she would see the public summary in the official record within 48 hours, and that the hospital's legal team had been informed. She found the summary in the board's public database the following morning, sitting at her kitchen table before her shift with coffee that was still hot enough to matter. The language was the calibrated language of regulatory bodies, precise and dry and carefully stripped of anything that could be read as editorial. But the substance was not dry. The board's preliminary finding determined that Dr. Elliot Drummond had, in the course of filing the incident report following the December 9th trauma activation at Hargrove Regional Medical Center, created a medical record that materially misrepresented the documented sequence of clinical events. The finding further determined that this misrepresentation was not consistent with inadvertent error, given its systematic nature and the direction of its deviation from the event log record. The board cited the applicable Oregon statute, falsification of a medical record in a context involving patient harm, and noted that the finding, if upheld in the formal proceeding, carried a mandatory minimum of license suspension and a maximum of permanent revocation, depending on the full evidentiary record. The formal proceeding was scheduled for 8 weeks from the date of the summary. She read it twice. She drank her coffee. She noted the specific flatness she felt, which was not satisfaction exactly, and not grief either, but the particular absence of feeling that sometimes arrives when something you have been waiting for finally arrives and turns out to be exactly what it was. Not a relief, not a triumph, just a fact. Drummond had made a decision on December 9th that had nearly killed a man. Then he had made another decision, the decision about the report, that had compounded the first one in a way that was ultimately uncontainable. That was the architecture of how people like him failed. Not in a single moment, but in the moment after the first moment, when the choice was between accountability and protection, and they chose the wrong one. She put the phone down and went to work. She was on shift when Drummond came to clear his office. It was a Tuesday afternoon, 3 days before his formal last day as chief. He came in the back entrance, the physician entrance off the parking structure, which she knew because Rosario told her. And Rosario knew because Rosario knew everything that moved through the building. He had a box. He worked for about an hour. He did not come through the trauma wing. He left through the same door he came in. She did not see him go. She was with a patient, a 44-year-old woman named Sandra, who had come in with a complicated asthma exacerbation and who was scared in the specific way of people who had been through this before and knew what it felt like when it became something worse. Sarah sat with her through the worst of it, talking to her in the steady, unhurried way that communicated to a frightened person that the person caring for them was not frightened. And when Sandra's breathing finally eased into something manageable, the relief on her face was the kind that had nothing to do with anyone's career or any committee finding or any document in any database. It was just a woman breathing easier. Sarah adjusted the nebulizer, updated the chart, and checked the time. Drummond was already gone. 2 days before the medical board's formal proceeding, Merritt called her. She was in the stairwell. The same stairwell where she had sat with Sutton, which had apparently become the place in the building where things happened outside of rooms. She answered on the second ring. "The board proceeding," he said. "You don't need to attend." "I know," she said. "I'm not planning to." "They have everything they need from the record." "Yes." A pause. Not the pause of someone who has run out of things to say, but the pause of someone who is deciding how to say the thing they called to say. "I've been thinking about Korengal," he said. She sat down on the step. Outside the stairwell window, the February sky was the gray of a system coming in off the mountains. "The declassification," she said. "That and the rest of it." He was quiet for a moment. "I wrote that after-action report personally. I told you that. What I didn't tell you is that I spent about a week trying to figure out how to write it in a way that did justice to what happened in that tent." A pause. "I couldn't. The document is good, but it's a document. It describes actions. It doesn't describe the person." She didn't say anything. "I'm telling you this," he said, "because I want you to know that I know the difference between the record and the person." His voice had an evenness that she recognized as the product of effort. "You saved Marcus Tully's life the same way you saved those men in Korengal. Not because you had better equipment or more time, Because you refuse to let the conditions determine the outcome. She looked at the window, at the gray sky. I had worse odds in Korengal, she said. Yes, he said. You did. 2 men still died. Yes. And 9 didn't. He paused. You know as well as I do that the math isn't the measure. The measure is whether you were still making decisions when most people would have stopped. She thought about that. About the specific weight of being the person who keeps making decisions when the conditions have exceeded what anyone designed for. I wasn't the only one, she said. Specialist Navarro was in that tent with me for 11 hours before the fever took him down. He was running blood panels on equipment that had no business functioning in that temperature. He's in the report. He's not in the public summary. A pause. I'll fix that, Merritt said. She believed him. Take care of yourself, Voss, he said. You too, she said. He hung up. She sat in the stairwell for another minute, listening to the particular silence of a building that was always making noise, the ventilation, the distant equipment, the movements of people doing work that mattered and didn't stop mattering because difficult things were also happening. And then she stood up and went back to her patients. The medical board proceeding lasted 2 days. On the 3rd day, the board issued its finding. She read it the same way she had read the preliminary finding, at her kitchen table, before her shift, with coffee. The language was the same calibrated regulatory prose. The substance was not preliminary this time. The Oregon State Medical Board found that Dr. Elliot Drummond had violated Oregon Revised Statute 67.190, which governed unprofessional conduct in the practice of medicine, specifically subsection 1, mem, falsification of a medical record. The board found the violation proven by clear and convincing evidence based on the automated event log, the facility's audio recording, the testimony of 2 physician witnesses, and the documentary record of the incident report as filed versus the sequence of events as documented by the facility's integrated systems. The board ordered a 12-month suspension of Dr. Drummond's medical license, effective immediately, with reinstatement conditional on completion of a medical ethics review program and a supervised practice period of no less than 24 months upon return. The board further ordered that the finding be entered into the National Practitioner Data Bank, which meant it would follow him to any future credentialing application in any state. She read to the end of the document. There was a section at the bottom, a brief paragraph from the board chair, which was unusual. Board findings were regulatory documents, not editorial ones. But the chair had included a statement that she read twice. It said, "The board notes that the clinical warning documented in this case was not only accurate but was documented contemporaneously and clearly in the patient's medical record. The practitioner who issued that warning and who subsequently performed the intervention that preserved the patient's life acted with clinical integrity under conditions that most practitioners will never encounter. The board's finding in this matter is not only about the falsification of a record. It is about the system that allowed a documented warning to be ignored and then allowed the person who issued it to be threatened with disciplinary action for being right. That system failed. The record is now corrected." She put the phone face down on the table. She sat with her coffee for a few minutes in the quiet of her kitchen. The ordinary quiet of a Tuesday morning, the sound of the street outside beginning its day, the smell of coffee, and the particular still quality of a moment that is complete. She was not triumphant. Triumph was not the word for this, and had never been the word for this. The word was closer to something like settled. The way a structure settles when the thing that was wrong in its foundation has been identified and addressed, and the building is still standing, and the work of maintaining it can continue. She got dressed and went to work. The internal communication went out that afternoon. Firth had drafted it himself, which she knew because the language had his particular quality, careful and institutional but not evasive, which was a combination he had apparently developed a taste for over the past 2 months. It went to all medical staff, all nursing staff, all administrative personnel. It covered December 9th. It covered the clinical standards review and its finding. It covered Drummond's departure and the board's ruling without editorializing, the facts in sequence, the regulatory outcomes stated plainly. It covered the Trauma Integration Working Group and the revised emergency exception policy, which had been finalized at the 3rd meeting and ratified by the Medical Executive Committee the previous week. And it covered Sarah. Not extensively. 3 sentences. It named her, stated her role on December 9th, referenced her military background and the Korengal after action in the declassified summary, and stated that her clinical privileges had been fully restored and that she had been appointed to the working group in an advisory capacity. 3 sentences. She read them standing at the nurse's station during a lull between patients, and she felt something move through her that was complicated and real and did not have a clean name. Pride was in there somewhere, but it was not uncomplicated pride. It carried the 2 men who didn't make it, and the 14 months before December 9th when Navarro was sick and she was processing things alone. And it carried the 32 days of suspension from the trauma rotation and the morning in Firth's office when she had not known what the committee was going to find. All of that was in the 3 sentences, whether it was visible there or not. Rosario appeared at her elbow, read the communication over her shoulder, and said nothing for a moment. Then she said, "About time." "Yes," Sarah said. "You going to say anything? To the department?" "I said what I had to say in December." Rosario made a sound that was half agreement and half something else. "Some of them owe you an apology." "Some of them moved when it mattered," Sarah said. "That's what I'll remember." Rosario looked at her. "You're a strange person, Voss." "I've been told," Sarah said. Drummond came back once. She had not expected this. It was a Friday afternoon, 5 weeks after his last day, and she was finishing a chart at the nursing station when she looked up and saw him in the corridor. He was in street clothes, not civilian professional, just ordinary clothes, the kind a person wears when they're not performing a role. He looked like he had lost some weight. His hair was slightly longer. He had the particular quality of a man who had been in one configuration for most of his adult life, and was now in a different one and had not yet learned how to wear it. He was not there for her. He had come to collect a final item from his office, a framed photograph, she learned later, of his residency class from 23 years ago, which had been left behind in the cleared-out room. He had apparently arranged with the department coordinator to pick it up quietly on a Friday afternoon when the wing was less busy, but he saw her at the station, and he stopped. She looked at him across the corridor. Neither of them moved for a moment. Then he walked over. He stood on the other side of the station counter. She did not get up. He did not ask her to. "The board's finding," he said. "Yes," she said. "I'm not going to contest it." She waited. "I want you to know," he said, and then he stopped. He looked at the counter between them, at the ordinary detritus of a nursing station, a pen someone had left without a cap, a stack of patient information sheets, a half-full cup of cold coffee that belonged to someone. He looked at these things for a moment as if they were easier than what he was about to say. "I knew you were right," he said. "About the intubation. In the room, in the moment. I knew." He said it without inflection, which made it worse than if he had said it with one. "I've been trying to understand why I proceeded anyway, and the honest answer is that I don't have a clean explanation for it. I had been doing this for 20 years without being contradicted by a nurse, and I didn't know how to do that. In that moment." He paused. "That's not an excuse." "No," she said. "It's not." "I know." He looked up at her. "What I did to the report, that I can't explain in any way that isn't what it was." She looked at him. She thought about what to say, and she thought about whether there was anything to say that would actually mean something, versus the various things that would sound like something and mean nothing. "The patient is alive," she said. "Whatever you did to the report, and whatever you did in that room, he is alive. Hold on to that." She paused. "But don't let it become the reason you stop looking at the rest of it." Drummond was quiet. 20 years, she said. "You were probably right far more than you were wrong. The problem isn't being wrong. The problem is what you do when someone else is right, and you're not ready to hear it." He said nothing, but something in his face absorbed what she had said in the way of something going into a place where it would sit for a long time. He picked up the photograph that the coordinator had left at the station for him. He walked out. She watched him go. She felt no satisfaction in his diminishment, and no residual anger either. What she felt was something closer to the particular sadness of watching a person who could have been something else make the choices that made them what they were instead. It was not her sadness to own, but she felt it anyway because she was human, and that was what humans did. She turned back to the chart. She finished it. Spring came to Caldwell the way it usually came, not all at once, but in the incremental way of weather that had been doing this for longer than the city had been there, the temperature rising 3 degrees one week and dropping back 2 the next, the foothills losing their snow line gradually from the top down, the hospital parking lot drying out, and then flooding and then drying again. Sarah ran her usual route on her days off, the same 4-mile loop she had been running since the first week, through the residential streets east of her apartment building, up the moderate grade toward the park, down the backside and along the trail that followed the creek before returning to the street. She had been running the same route in various cities for 11 years, adjusting the distance to whatever the new place offered, but keeping the basic architecture of it the same, because consistency in small things was how she managed the inconsistency of everything else. She was finishing the last half-mile on a Saturday morning in late March when her phone buzzed in her jacket pocket. She didn't break stride. She checked it when she reached the apartment building entrance. It was a message from Mia Sutton. Match day results came out this morning. I matched at my first choice. Trauma Surgery Fellowship, University of the Pacific Medical Center. I wanted you to know. She read the message. She stood at the entrance to her building in her running gear with her heart rate coming down and the particular March light that was almost warm but not quite yet. And she felt something uncomplicated and clean, which was a rarer experience than most people understood. She typed back, "Congratulations. You earned it." Then, after a moment, she added, "Say what you see, in sequence. You'll be fine." Sutton sent back a single word, "Always." Sarah put the phone in her pocket and went upstairs. The Trauma Integration Working Group finalized the revised protocol in April. The document was 42 pages, which was approximately 38 pages longer than the original Section 4.3, and contained specific escalation pathways, real-time documentation requirements, independent clinical review triggers, and a provision that Sarah had fought for across 3 meetings: a mandatory secondary consult requirement whenever a nursing staff's assessment of imminent hemodynamic collapse was documented, and the attending physician's management decision deviated from that assessment. Not because nurses were always right. She was clear about that in every meeting. Nurses were not always right. But the documented assessment existed in the record, and the deviation existed in the record. And if the deviation produced the outcome the assessment predicted, the record would show it, and someone would be accountable to it. That was the whole of it. Not perfection. Accountability. The protocol went to the Medical Executive Committee in April and was ratified without significant modification. Osei called her after the ratification meeting. "It passed," he said. "I know. No, Rosario texted me." "Of course she did." He was quiet for a moment. "Firth wants to know if you'd be willing to present the new protocol at the Regional Trauma Conference in June. Hargrove is hosting this year." She thought about that. A room full of trauma physicians and nurses from across the region, some of whom would know the context of the protocol's origin, and some of whom wouldn't, all of whom would be receiving information that could change how they practiced on a specific category of high-pressure mourning. "Yes," she said. "I'll tell him." A pause. "You should know, the conference keynote is a joint address. 2 speakers. Osei named the second one. Me and you." She was quiet for a moment. "You don't have to," he said. "I said yes," she said. "Okay then." She hung up. She was in the break room. The coffee was bad. The chair she was sitting in had a wobble in one leg that she had been meaning to report for 2 weeks. The overhead fluorescent had a slight flicker at the far end that nobody had fixed since February. All of it was exactly what it was supposed to be. She had one more encounter that mattered. It was a Tuesday in May, a morning shift, the kind of ordinary morning that existed to remind you that most of them were ordinary: patients to assess, medications to prepare, a set of dressing changes that required more time than the schedule had allocated, the usual small negotiations of a care environment that always had more need than capacity. She was coming out of Bay 4 when she nearly walked into a man in street clothes standing in the corridor with a visitor badge and a slight hitch in his gait that told you, if you knew what to look for, that his pelvis had been reconstructed and he was still learning to trust it. Marcus Tully. He was taller than she remembered, which was not logical since she had mostly seen him horizontal, but there it was. He had the kind of face that had weathered things and kept going, not unaffected, just continuing. He was holding a small paper bag with the logo of a bakery near the hospital, the kind of place that catered to visitors who needed something to do with their hands when they came to say thank you. He looked at her badge. He looked at her face. "Sarah Voss?" he said. "Yes," she said. He extended his hand. She shook it. "I've been trying to figure out how to do this," he said. "I asked the front desk twice, and they kept telling me visiting hours, and I finally I walked in." He held up the bag slightly. "I brought things from the bakery. I didn't know what else to bring." "You didn't need to bring anything," she said. "I know." He looked at her. "They told me what you did. Merritt told me. He told me all of it." A pause. "He told me what it cost you." "It's been resolved," she said. "I know that too." I was quiet for a moment in the way of someone who has been thinking about what to say for a long time and is now discovering that the thing he prepared is not exactly what the moment requires. "I have a daughter," he said. "I know." He looked at her. The corridor was its usual self around them. Movement, noise, the ambient hum of a building doing what it did. None of it paused. "She still doesn't entirely understand what happened," he said. "She knows I was hurt. She knows I came here. She knows I came home." He paused. "She's going to understand the rest of it someday. And when she does, I want her to know the name of the person who—" He stopped. He looked at the bag in his hand and then back at her. "She doesn't need my name," Sarah said. "She's going to know it anyway," he said. "I'm going to make sure of that." She looked at him. She thought about the 7-year-old in the red coat with her hand on the arm of the wheelchair, telling her father everything that had happened while he was away. She thought about what it meant to be the fact in someone else's story. Not the story itself, just the fact that made the story possible. "Go home," she said. "Go home and let her tell you what you missed." He nodded. He held out the bakery bag. She took it. He walked back toward the elevator with the careful gait of a man who had learned not to take the mechanics of walking for granted. She watched him until the elevator doors closed. Then she looked down at the bag. Inside, 6 small pastries in a wax paper sleeve, the kind that had no particular significance except that someone had chosen them for a specific purpose, which gave them a significance the pastries themselves had not been aware of. She brought them to the break room. She put them on the table. She didn't explain where they came from. People took them over the course of the next hour without commentary, which was exactly right. She stood at the trauma bay entrance on a Thursday in late May, at the start of a shift, and she looked at the room the way she had looked at it on her first day. The monitors, the equipment, the cabinet in the corner, the specific quality of light that trauma bays had everywhere in the world. A light that was functional and unsentimental and that existed entirely in the service of what happened under it. She thought about the morning that had started all of this, not with nostalgia and not with anger, just with the clear, factual attention she brought to everything. She had come to Hargrove Regional as a nurse nobody had bothered to know. She had been filed away in the category of field-trained non-physician, useful in limited ways, unreliable in the ways that mattered. She had been warned, suspended, threatened, and documented against. She had been the object of a formal complaint designed to end her career in this building. And she was still here, not because of merit, not because of the audio recording, or the timestamps, or the board's finding. All of those things had helped, and she was not naive enough to pretend that the outcome would have been the same without them. But the reason she was standing at this trauma bay entrance on a Thursday morning was that she had kept showing up. She had documented her work from the beginning because she understood that records protected people who did not have institutional power. And she had been the kind of person who noticed what needed to be noticed before it was convenient to notice it, and she had reached for the cabinet when the alternative was watching someone die in front of her. She had done the work that was in front of her, consistently, without waiting for the conditions to be right, because the conditions were never right. They were just the conditions. The pager went off at 7:03. Trauma activation, single patient, motor vehicle, ETA 9 minutes. She walked into the bay. Horton was already there, and Rosario and 2 residents she had been working alongside for 3 months, who had learned something about what it looked like to bring your full attention to a room without apology. They moved into position with the organized efficiency of a team that had been through things together and had come out the other side with a specific mutual regard that was not the same as friendship, but was not less than it. "What do we have?" Horton said. Sarah looked at the door. "We'll know in 9 minutes," she said. "Be ready." The room was ready. She was ready. The doors opened. And Sarah Voss, The nurse nobody had taken seriously, the woman the record had cleared, the practitioner the board chair had named without hesitation in a regulatory document, the person Merritt had called something else in a valley 7 years ago that had finally, imperfectly, incompletely, and without flourish become part of the public record, went to work. Because that was who she was. That was who she had always been. And no one in that room, on that morning, or on any morning after it, would make the mistake of forgetting it again.